Hey, this has been watching. Are we live yet? Hey, this is Dr. Watson. Are we live yet?
Joint House and Senate Committee on Evaluating Escalating Costs in Georgia's Foster Care System. Co-Chairman Beth Camp and I both understand the importance of this committee in helping to understand the existing framework of delivery of services to our most vulnerable children. We intend to ensure that future resources are available to achieve the best possible outcomes for foster kids. That's why, although we've had 2 Senate study committees in the past few years about various aspects of our foster care system, we want to engage both chambers. And we also want to include the agencies that have various responsibilities related to foster care, the governor's office, and the nonprofit sector. You'll see that reflected in the committee membership, and they'll introduce themselves in just a moment. We know that the cost of out-of-home care services has increased by 159% since 2022. We also know that other states are dealing with similar increases in costs. The mismatch in costs versus appropriated funds last year resulted in an unexpected budget deficit for DHS, which was covered by the General Assembly. And we know that increased costs are impacted by many variables and that we need to understand these in order to avoid future deficits while still providing needed services. This committee is not about blame or finger pointing. We're looking for thoughtful and respectful consideration of this complex topic. Because the committee is so large, we'll have presentations from the various agencies, some today and some in future meetings, but only the legislators will be asking questions. There will be time for further testimony at future meetings. We have 3 committee members attending virtually on Zoom. We have a lot of information to cover, and we plan to have 2 additional meetings. The next one is scheduled for September 17th. It may or may not be in this specific room because, as you can see, all our chairs are full. The committee's report is due December 1st with our recommendations, and we're also expecting a report from the Department of Audits and Accounts in September. We'll discuss that information at a later meeting. We'd like to ask the legislative members to keep your questions concise and to the point so that we can stay on schedule. Today's meeting is for gathering information so that the committee will be able to operate from data and separate that from emotional responses to this very important subject. So with that, I am guessing that Chairman Camp will have some remarks as well.
Thank you so much, Senator Kirkpatrick. Thank you all for being here today, and thank you to all the members of the committee for your time being here, your objectivity in addressing this subject. One of the most important things we can do, I think, as members of the General Assembly is to protect the vulnerable members of our state, and the vulnerable members of our state being children that are in foster care and children who are impacted by DHS. To understand fully what the out-of-cost escalation involves is very important. For lack of a better term, in the past, we haven't holistically perhaps addressed this. Things are always changing, as Senator Kirkpatrick said. There are so many variables that come into play and why costs have escalated. But we have a huge responsibility to the taxpayers of our state as well to make sure that we are putting money where it's needed, and most importantly, to make sure that services are delivered to those children. So again, thanks everyone for being here. I certainly appreciate Speaker Burns and Lieutenant Governor Burt Jones. I appreciate the governor for the faith they've all placed in us that we're going to be able to figure this out. So thank all of you, and we look forward to any testimony today.
Thank you so much. I'd like to get the committee members to introduce themselves briefly and who they're representing today. So we'll start down there with Juanita Stedman. Hang on, let me turn your mic on. Are you 16?
Juanita Stedman, I'm the Executive Director of Together Georgia. For those of you who don't know, Together Georgia is the largest provider organization in the state of Georgia. So it includes the providers who care for these children in various different ways. So I'm going to present later, so I'll talk more later. Thank you.
Good morning. My name is Lynette Rhodes. I am the Chief Health Policy Officer with the Georgia Department of Community Health, and DCH administers the Medicaid and the Peach Care for Kids programs in the state of Georgia. Thank you for the opportunity.
Hi, good morning. My name is Dr. Christy Doyle. I'm the Senior Director of the Office of Children, Young Adults, and Families for the Department of Behavioral Health and Developmental Disabilities. And our office manages those children who are uninsured, underinsured, and various programs such as Apex Match, et cetera. Thank you.
Morning, I'm Lindsay Burton, and I'm representing the Council of Superior Court Judges.
Good morning, John Albers. I serve in the State Senate District 56, which is North Fulton, Cobb County, and Cherokee County, and I chair the Senate Committee on Public Safety.
Hello, I'm Representative Joseph Gullett, representing House District 19, which is East Paulding and West Cobb County. I chair the appropriations for judicial in the House, and I'm also a foster parent and an adoptive parent.
And this is Daly Kennedy. She assists me in everything that I do down here. And if anyone has written information that they want to submit to the committee, Daly Kennedy is your person.
Hi, I'm Beth Camp. I'm co-chairing this committee. Represent House District 135, which is in West Central Georgia, and I'm the chair of the House Judiciary Juvenile Committee.
Good morning, I'm Esther Panich. I'm the state representative for House District 51, which includes parts of Sandy Springs, Roswell, and Johns Creek.
I'm Mary Margaret Oliver. I represent House District 84 in DeKalb County, middle of DeKalb County, all the way to southeastern DeKalb.
I'm McCracken Poston. I'm the president of the Council of Juvenile Court Judges. Before that, I was a member of your state house for 4 terms.
Good morning. I'm Lee Moss. I am a Special Assistant Attorney General for Morgan, Greene, Jasper, and Putnam County DFACS, and I represent DFACS in dependency proceedings in juvenile court.
Good morning. I'm Senator Kenya Wicks. I represent District 34, which encompasses Fayette and Clayton County. Thank you for being here.
Good morning. I'm Candace Brose. I currently serve as the Commissioner of the Georgia Department of Human Services, Tax Director, and I've held both of those roles since basically mid-2021. Before that, I worked in the governor's office as Chief Deputy Executive Counsel in the state COO.
And we have a few people on Zoom. I can't read the names right now, but I see Senator Hatchett up there. Who else is up there? Okay, anybody on Zoom?
Hey,
Ben?
can you hear me?
Yeah.
It's Ben Watson, down here in Savannah, chair HHS and chair of the subcommittee on health appropriations in the Senate. I'm going to be on Zoom today, but listening in, looking forward to the discussion.
Thank you. Who else we got on Zoom?
Hey, Kay, Chairman, this is Bo Hatchett, State Senator for District 50. I've had the pleasure of serving on the Senate Committee for Children and Families for the past 4 years. I've been in the Senate for 6 years and look forward to serving, and I'll be on Zoom today. I couldn't make it in person, but I'll be listening in and participating.
Thank you.
Hi,
I think we have one more person. Yeah, go ahead.
Hi, this is Shanice Howard. I'm the Director of Federal Revenue Maximization at Department of Juvenile Justice. I'm sitting in for Commissioner Sharonda Reynolds Cobb.
Thank you very much. And I'm sure that everyone knows that we're also live streaming this committee meeting, and it will be archived for future review for people who can't make the meeting. I'm Kay Kirkpatrick. I represent Senate District 32, which is Cobb and Cherokee counties, and I'm chair of the Children and Families Committee in the Senate. I wanted to recognize the Casey Family Foundation, and we have become very tight over the last few years as they have presented us with some great data and information about foster care across the country and also specific to Georgia. And they've got more data for us today. So Katie Storr, you want to come on up? It may take us a minute, presenters, to get your presentations loaded. So don't panic. We have one, before we start your presentation, we have one additional committee member who's joining us.
Good morning, Senator Rashawn Kemp, Senate District 38, which is portions of Fulton County.
Thank you. Okay, Ms. Storr, the floor is yours.
Thank you. Just make sure I can. Get these to advance. I'm sorry, I'm just having trouble advancing this. These ones. Okay, great. Thank you. Sorry about that. Good morning, and thank you, Senator Kirkpatrick and Representative Camp, for the opportunity to join you today. My name is Katie Storr, and I have the honor of serving as a Managing Director of Strategic Consulting at Casey Family Programs. Prior to joining Casey, I spent the previous 2 decades working in child welfare in both the public and the nonprofit sector in 3 different states, most recently serving as the first Deputy Commissioner of the New Jersey Department of Children and Families. Casey Family Programs is the nation's largest operating foundation focused on safely reducing the need for foster care and building communities of hope for children and families across the United States. Casey works in all 50 states, the District of Columbia, some of the U.S. territories, and with many tribal nations to influence long-lasting improvements to the safety and success of children and families. We love what we do, so we're always happy to have opportunities like this to share information about our field. I am going to...
Some that flew in from Seattle last night.
Yeah, I did. So I was just about to come to that. I don't normally like to speak like right off of notes, but I'm going to have to rely on some of that today. So sorry about that. Let's see if I can. Oops. Okay. I was asked to join you today to share some information about national trends in child welfare and some of the factors that we know can influence the cost of delivering child welfare services. And, I was just listening to all of you introduce yourselves and thinking about, I was speaking with my colleague about a health issue I've had recently, which is orthopedic in nature. And so when you have joint issues and you go into physical therapy, they're going to work on looking at everything around that joint. How are the muscles working? How are the bones aligning together? What's going on? That's what I'm hoping to provide for you today, is some of that context around the problem that you're trying to examine. So before we get too far along, I want to share a touchstone for my remarks this morning, which is this challenge that you see on the slide. What outcomes do you want for Georgia's children and families? Budgets are tools to achieve outcomes, and it is just about impossible to design a budget appropriately if you don't have a shared understanding about what you're trying to get done. So the core question, I'm going to give you a lot of details, more than, I hope I don't put you to sleep, because I could talk for a long time about child welfare, maybe more details than you want this morning. But I hope we don't get lost in the sauce, because this is really the most important question that any of us can have in front of us. Oops. Maybe by the end, I'll learn how to work the slides. During our time together, I'll aim to provide, in that context, about the general child welfare operating environment, some information about these 4 core areas. What services are we talking about? Getting clear about that. Just a little flashback to any of us who had Econ 101. Mine was in the last century, but supply and demand is still true. So that's in front of us. And then we can look at some things that are impacting the demand side of things, and then some things that are impacting the supply side of things. Okay. Maybe. Okay. So let's start with what are the services that we're talking about.
This is the mission for child protection or child welfare systems that's given to us by the United States Department of Health and Human Services. And I won't do this again in this presentation, but I'm just going to pause and ask you all to just read it for a moment. There's a few important elements in this charge that we have. One of them is that our first mission, the very first thing we're trying to get done, is to strengthen families so that children can stay safely with them. It's first and foremost keeping families safely together. Next, it talks about if that kind of prevention has failed, or if abuse and neglect has already happened, systems have to offer services and supports to ensure that it doesn't continue. And then we see that foster care is presented as kind of a last resort option, only if the other two options haven't worked. Broadly speaking, this mission gets operationalized in this basic format. I've labeled this Any State USA, this flow chart, because I don't know enough about your system here in Georgia to be too terribly precise about it. But this is a rough flow chart of how we get to the point of providing services in child welfare. In general, the first actors in the child welfare system are the people. They're often doctors and nurses and teachers and law enforcement officers who are concerned that a child may be maltreated or may know that a child has been maltreated, and they're going to make a report to a child abuse hotline. That hotline is going to gather the information from the reporter and make a determination about whether the allegation, whether those circumstances meet that threshold to launch an investigation. And there's generally a statutory guidance around what merits an investigation or what does not. Some states, and I think Georgia is one of them, have an alternative response option so that instead of providing an investigation, there's an option if it doesn't meet that threshold that the department can offer some services and supports to that family outside of the context of doing an investigation. If an investigation is opened, part of what the investigator is gathering information to do is to help her make a safety decision. And that's really critical. That's the decision of, do we think, based on the information we have, that this child is safe right now in the home? Do we think this child is not safe right now? And if the child's not safe, what would need to be done in order to help us think that this child can be safe? And sometimes that's going to a court to seek various orders for things to happen, which could be in-home services, but it could be removal of that child and placement of the child into foster care. And then at the far end, there can be post-permanency services that are delivered after a child has been reunified or adopted or placed in another guardianship arrangement. My goodness, I'm so sorry to be struggling like this. There we go. I will share some data throughout the remarks this morning, and I just want to note to you the data sources that we're using at Casey Family Programs are from federal reports that every state is required to submit, and we do that so we can have an apples to apples kind of comparison across states or aggregate national data. If you were to look at your department's data, it's going to be more recent than the data that I'm showing to you. So I would not, if you were to go on a website for the department, the numbers probably won't exactly match what I'm showing you here today. That doesn't mean that no one's done anything wrong or nefarious. It's just about data collection periods. But this data is going to show us just what volume of children are we talking about here. You have over 2.5 million children living in Georgia. About 130,000 of them are part of an investigation or an alternative response in a given year. About 12,000 of those, 13,000 of those are determined after an investigation to have been maltreated. And in general, there's about 10,000, a little over 10,000 children living in foster care. This was as of 2024. So those data in the last slide showed us that over 100,000 children are involved in the reports that are screened in. That's on kind of the left of this chart. And around 10,000 are in foster care on the right end of the chart. The services that I think you're the most concerned with are on the right side of that chart. They're the most expensive services for the fewest number of children that we're kind of talking about in this flow chart. But just to be clear, there usually are services that are in play a little bit at any point in the flow chart. So for example, during an investigation, we might need to get support from a forensic evaluation, like a psychiatric or a medical evaluation. There can be services offered to families to try to keep things stable and safe at home throughout an investigation or into in-home services. But the very expensive services are once a child is in custody, and that's family foster care. Might have treatment foster care. It's all the camps and after-school activities and transportation and everything that's associated with child rearing. And then if that child is ending up in a group setting, like a residential treatment setting, that's where things get very expensive. Often those are over six figures per child per year. So that's a little bit of an overview about how do we get to provision of services. There's a lot of stuff that happens: call to the hotline, an investigation, a safety decision, efforts to try to prevent the need for placement, and then before you ever get to placement itself or incur the cost of any of those services. So when we talk about cost, of course, we're back to supply and demand. So here's how that works, as we all know. When a lot of people want something and there's not enough of it, price goes up. When not that many people want something and there's a whole lot of it, price goes down. So we ought to care a lot about what's driving the demand. When demand is going up, we're going to have some issues if the supply isn't going up in a way to meet it. And similarly, if the supply is going down, we're going to have some issues if the demand isn't going down to meet it. So I'm offering that as a frame for kind of analyzing or thinking through the rest of these issues here today. All right, so what's influences demand? These are some of the things. It's not everything, but I'll walk through prevention efforts. So that whole flow chart, getting to the right where kids are in foster care, the more you can do to keep those numbers down safely, the less expense you're going to incur because you won't have as many children living in foster care. There's sometimes around the country, different states, where there's some pressures on child welfare systems asking them to do things that they're not really built to do. So I'll talk about that a little bit. There are legal structures around foster care. There's federal statute that requires what's called reasonable efforts. I'll say what that is when we get there. That has an impact on services. And then, of course, if you're thinking about kids who are in foster care, making sure that that's temporary, that the amount of time that they stay in foster care is another way of looking at the population of kids in care. So the first one is prevention, and this is, of course, a universal truth. I know that there are some physicians on your committee, so I'm going to use another medical example, and you can go, oh my goodness, if I'm wrong. But I think about foster care. My father had to have quadruple bypass surgery a number of years ago. Now I think about foster care kind of like open heart surgery. We all know that it's something we never want to have, and yet it can save our life if we need to have it. But we, over the last several decades, we've learned a lot about the need to maintain a proper diet and good nutrition, to exercise, keep our stress levels in check. These are all, we could think of these as primary prevention efforts, things all of us should do. You don't have to qualify for it. It's not only if you have a certain thing going on. We should all have a good diet and exercise and keep our stress levels in check and all that kind of stuff. But if we start to show signs of trouble, there's another kind of prevention we can think about. To belabor the medical metaphor, that might be things like statins or getting a stent put in. These are prevention, trying to prevent you from having a fatal cardiac event, but not everybody needs a statin. Not everybody needs a stent put in. Those are, I'll call those secondary prevention for our conversation today. It's for a specific population trying to do a specific thing. So in child welfare, that primary prevention is so important, and it's all manner of things that can happen kind of far to the left of where this diagram even begins, the kind of things that can happen for everybody. We could think about this as, what could we do to reduce the need to call the child abuse hotline to begin with? What would it be like if we just didn't have as many concerns for children? If we don't have a concern about a child to begin with, none of the rest of this process is necessary. We just don't even get to the far right end of this graph. So the easier we make it for families to get what they need, the less often we have situations of concern and the less demand we'll have for child welfare services. So what does that kind of prevention take, and whose job is it? My boss, Dr. David Sanders, I heard him say something probably about 10 years ago that I've never forgotten. Any of us who were around in the 80s will remember Smokey the Bear. Who can prevent forest fires? Only you, right? And what Dr. Sanders will say is Smokey the Bear never said only the fire department can prevent forest fires, right? It's a collective responsibility. Child maltreatment is just like that. It's not only the CPS department's job to prevent child maltreatment. It's all of our jobs to do that. This work happens as all of us as neighbors and community members and extended family and friends. This is a slide I designed in another job in another state, but I liked my work, so I'm sharing it with you here today. And the idea is the first part of a family strengthening system is that family's own extended family and their natural connections. That's, again, it's us as neighbors and friends and parents at the bus stop and all kinds of stuff like that. But you can see that there's all manner of professions who work with parents and work with children all the time. And the success or failure of all of that work contributes to how much is going to spill over into the formal child protection system. So if people are getting what they need, we'll have less demand on the child protection system. And as you might imagine, looking at the list of components that are kind of there in that light blue box on the left, there are a myriad of federal funding streams that can be leveraged in coordination to provide help to families to keep them strong in ways that prevent child maltreatment. No matter what form it takes or who is doing what, we know a fair amount about what this kind of primary prevention work needs to accomplish with families. This is a list of what are called the protective factors. They were developed by the Center for the Study of Social Policy after a review of a lot of academic literature about what is most impactful in preventing child maltreatment. You can see, I won't read through all of these here, but it's good. They're good questions for any of us in this field to be asking when we're thinking about primary prevention. Are parents isolated, or are they connected? Are they living far from family, or are they connected to people in their own neighborhood and community? Do they have family nearby who they can rely on if they get stuck, if they have an emergency in their family? Do the adults in a child's life have realistic expectations about what kids are going to behave like and what they're capable of at different stages of development? Can parents access things that they're going to need in order to be raising their family, like childcare or transportation? If they have a medical or a mental health problem, can they get health care and help for that in a timely way? These are all things that play into preventing maltreatment of children. And so the more that we're doing to promote these factors through all those helping systems that I showed earlier, the more we're going to be doing to reduce the likelihood of child maltreatment. And that in turn impacts the demand on the child welfare system. And then there's this other form of prevention, my sort of statins and stent example, which is secondary prevention. And that kicks in, it's not preventing the need for maltreatment. We're further down the flow chart now. Now we're looking at, we've done an investigation, and what could we do to keep this family safely together and avoid the need for foster care placement? I'll quote my boss again. He'll say, we've never found a better substitute for families than families. So that's the why of that. Why would we want to do that? Sometimes there is no other option and we have to pursue a foster care placement, but it needs to be a carefully calibrated decision, just like open heart surgery, which carries risks with it. There are risks associated with foster care placement as well. Children biologically need a consistent caregiver, so that gets disrupted even if it's not ideal at home. That early childhood period in particular is so sensitive. Emotional, cognitive, and social adaptive behaviors are formed between children and their parents in a particular environment. And even when that environment's not ideal, just changing it has an impact on the child. So it's kind of this calibration decision that has to be taken, and it's a really serious one. So it's possible to construct services, and I'm sure you have some here that are designed to prevent the need for foster care placement altogether. Some examples: some states have substance abuse treatment programs where new moms can live with their infants and receive treatment at the same time, and they're doing that together so they can maintain the work that they need to do as parent and child around attachment and bonding. Sometimes there are intensive family preservation services, which will go into a home on a day-to-day basis and do whatever's needed to try to keep that family out of crisis and resolve what's going on. All of those kinds of things are in keeping with that mission that I shared with you at the top of the presentation around strengthening families so that children can depend on their parents. Thinking about what it would take to safely prevent the need for foster care placement, it helps to know more about what are the circumstances the family is struggling with. You can see here that some of the most common issues presenting in Georgia, and these are really similar around the country, include things like caretaker substance abuse, housing, sometimes child behavior. This kind of information, knowing what are the circumstances that are in the family or that the family's having a hard time with at the time of removal, can help us get really smart about how to construct programs and supports that can intervene even at that crisis moment to try to keep families stable and keep kids together. So just sharing this data for you to think about as you go along. I'm going to share a few slides that show you comparisons of Georgia to the national average in terms of use of foster care placements, just so you have a way to kind of locate that. Anytime we're doing this, it's not at all a value judgment. It's not saying the national average is ideal or that something is better or it's worse, but it's just a way for you to understand if the way that a particular state functions is different than kind of what the rest of the country looks like, or if everybody's more or less in the same place. In terms of the use of foster care placement as a safety intervention, Georgia looks pretty much like the rest of the country, pretty close to the national average. In terms of the use of that for infants, which is kind of called out there on the right, infants enter care much more often than children of other ages. That makes sense when we think about infants. They're not physically able to protect themselves. They're not verbally able to ask for help if they need it, right? So that happens a fair amount. And that Georgia looks like the rest of the country in that regard as well. And that call out on infants is a call for us to think more about infants too, because we want to try to get that squared away in a different way. Here's another way to look at this in raw numbers, just the volume of children who are in foster care at any particular point in time. So you can see some ebbing and flowing of that volume here in Georgia. The next factor that I'm going to talk about is the child welfare system being asked to perform any kind of functions that it wasn't really designed to do. This happens a lot in a lot of different parts of the country, and I don't know enough about your state to have an opinion or anything to offer about this dynamic here in Georgia, so I'm just speaking very generally. But there are a lot of public systems that serve children. Children's behavioral health is, you can correct me if you feel differently, but is largely there to provide treatment for children, to help reduce their symptoms, to help them to heal from something that's going on. The success could be measured in terms of reduced symptomatology, increased engagement in school or social or family life. In other words, largely the child is the patient. Often the family needs to do some things with that child in terms of treatment. But the point of the intervention is about the child and her symptoms, her behavior. In child protection, it's different. It's a different purpose. It's not designed for treatment. It's designed for safety. And so safety, permanency, and the well-being of children who are involved in the CPS system is the center of that. Children come to the attention of the CPS system because somebody's called a hotline with an allegation that a caregiver's action or failure to act is harming a child. And success is thought about in terms of reduced maltreatment or reduced repeat maltreatment. And the point of the intervention is largely about the caregiver, trying to change the caregiver's behavior or circumstances, so that the children's behavioral health care system is really focused on that child and their health. The CPS system is really focused on the whole family system, and that a lot of times involves changes of behavior or circumstance for the caregivers. The juvenile justice system has a purpose that's largely focused on rehabilitation of the young person. Children come to the attention of that system because of an incident where they've committed some kind of an offense. And success might be thought about as reduced recidivism. We don't want that offending behavior to happen again. So that system is much largely about the youth's behavior change. These systems, some families are involved in all three. I didn't even talk about education, all four, all at the same time. Because we're people, we don't fit neatly into boxes. But it's important to understand that they each have a different function. They're here for different reasons. And while somebody might need help from all of them or multiple of them at the same time, they really are there to do different things. Sometimes in lots of parts of the country, though, it gets really complicated. And there's some conflation in the sense that the child welfare system usually has the largest capacity of places to sleep at night. It just has more beds than the other systems. And so that creates some dynamics where it starts to get asked to do things that it really wasn't designed to do. It's important to call out the differences in when a child is going to go sleep somewhere other than their home in a night. Custody through the CPS system is designed for instances when the caregiver is doing, like abuse, or failing to do, like neglect, something, and that behavior is creating a threat to the child's safety. So we have to have a parent, we have to have an action or a failure to act, and we have to have a threat to a child's safety. We also have to make reasonable efforts to try to avoid placement as the way to keep the child safe. And I'll talk about that again in a minute. Custody through CPS is not designed for situations when we don't have those elements. Maybe the caregiver is doing everything that a reasonable person could do, but yet there's still some behaviors that are not great with this youth, or even the youth is violent. But if the caregiver is doing everything that they could be reasonably expected to do, that's not necessarily abuse or neglect. And so custody through a CPS lane, that's really not what it was built for, if that makes sense. The child could be at risk in the community. They could be gang involved. They could be in some sort of beef with other kids in their neighborhood. That doesn't mean that the CPS system is the right place to turn to through a CPS, I don't know how to say this, sort of pathway of access, right? Because we don't have an action or a failure to act on the part of the parent necessarily in that situation. Similarly, with the child's behaviors posing a risk to self or others. So these are, again, any one family might need help from lots of different places at the same time, but the CPS system is not the same thing as a treatment setting in its design, unless your statutes have designed it that way, but most states have not. And it's not the same thing as a juvenile detention setting for the same reason. So that calls a couple of questions back to demand. Is there a demand from stakeholders at the call to the CPS hotline stage where somebody's calling that hotline expecting that the CPS system is going to be able to get the kid to behave differently? That would be a kind of demand that is out of step with what a CPS system is designed to do. And then further along at the placement end, are there situations where a child's being placed into CPS custody even when we don't have a concern about parent protective capacity? That again would be a demand on those more expensive placement settings that isn't really in keeping with how CPS systems were originally designed, unless again you have different statutes in your state that set it up differently. Some states and the state I most recently worked in New Jersey have built public child behavioral health systems to address some of these children's behavior, children's mental health concerns. For example, in New Jersey, it's called the Children's System of Care. And I think you have a system of care approach here in Georgia as well. And I'm not going to speak about yours because you know it better than me. But in New Jersey's, that includes a 24/7, 365 hotline. It includes mobile crisis response. That mobile crisis response is effective in avoiding foster care placement, arrest, and hospitalization over 90% of the time safely. It involves care management. So one thing that's true if you have a child with serious behavioral health care needs is you're going to be doing a lot of stuff. You're going to be going to IEP meetings in your school. You're going to be dealing with evaluators and hospitals and therapists. And that is really a lot for a parent to try to navigate alone. Any of us who've called a health insurance company with something complicated, you know right? You got your little file in your desk. So these care managers are there to help parents navigate that because it's just hard to do. It's really hard to do. It involves in-home and community-based intensive therapies. So trying to bring the treatment to the child that can be delivered in their home, or if they're not wanting to do that in home for any variety of reasons, it could be done at another safe location that the family agrees to. And it also includes treatment, family foster care, but not because of an abuse neglect petition, because of a treatment reason. And those foster parents are trained and part of a clinical team that's designed that way to be a clinical team. And it includes residential treatment services as well. That in New Jersey, which is where I live, that system is available to my children if they ever were to need it. That's available to adjudicated youth who are involved in the juvenile justice system. And that's the treatment system that children in foster care use too. But it's designed and it's called a behavioral health care system. And then the CPS system is designed and called the child protection system. Robust systems like that can reduce some of this inappropriate demand on the CPS system. And I won't say it solves everything because it doesn't, but it helps to bring some role clarity around who's involved in the child's life and that family's life and for what reason and what each person in that equation is trying to get done. Okay. Another demand here. I promised reasonable efforts a couple times. Let's talk about that. Reasonable efforts requirements. So I have a citation up there. This is a statutory requirement that's in Title 4E of the Social Security Act. I hope I got that citation right. All the lawyers in the room can tell me. But it kicks in two areas. One is around this notion that foster care placement has to be the intervention of last resort. When the worker goes before a judge and petitions the court for the authority to place that child into foster care, they have to provide evidence that they tried a whole lot of other things before getting to this decision point. And if they come up empty-handed, the judge is going to say, right? You have to have reasonable efforts to place that child into foster care. And those reasonable efforts often include services that have a cost. So that's a factor in demand. There's another point where reasonable efforts determinations come into, I'm sorry, if the department fails to prove that they made reasonable efforts, there will be no federal match to the cost of that child's time in foster care. So there's a withholding of federal funding that is associated with that. The second place where it kicks in is around if the child's been in foster care and the efforts to help the caregiver change their behavior or their circumstances are not working, and the state is looking to terminate the parent's rights to their child. Once again, the state has to prove that they made reasonable efforts, tried everything that under the sun that made sense to avoid taking that very drastic step, permanently severing the parent's rights to their child. And those reasonable efforts include things like treatment and rehabilitation services for the parent, what have we done around visitation, all kinds of things like that. Throughout the course of the case, in order to think about these reasonable efforts determinations that are required by law, the judge may also weigh in with orders that he or she feel are going to build that reasonable efforts that are necessary in the case. For example, often this will come up around parent-child visitation. Just like in private custody disputes, the judge has a role in setting up the frequency and the duration of the time that each parent, could be both of them, together or separately, gets to spend with their child. If children are not living together in foster care, then we have to be concerned about the time that siblings can get to have with each other. And, kids go to school. So the time of day when all this visiting has to happen is usually like 3 p.m. to 7 p.m., Monday through Friday and weekends. It gets really hard. It's hard. I have personally a shared Google Doc with 2 other families. That's how we manage carpools in my own personal life. Imagine that for 10,333 children. It's really complicated. So that is a factor on demand. Lastly, around demand, how temporary is the time in foster care? And I got some more data for you to show you here today. So this matters today's conversation for two reasons. The first is that once a child enters foster care, the longer she stays in the system, of course, the more cost is incurred. Every day that the child is in foster care, we're talking about food and clothing and the stipend to the foster parent and summer camp fees and activities and doctor's offices visits and all kinds of stuff like that. But the second is that, generally speaking, the longer the child stays in foster care, we start to see some other behaviors that would be predictable because she's not living with a family and she doesn't know what her permanent family situation is going to be. And so we can end up with some symptoms that are escalating that require treatment that are really there because we're talking about a temporary stay situation. So we want to keep foster care temporary. This is data again about Georgia in the national context. And again, it's not a value judgment that something is good or bad. It's just a comparison. It looks like Georgia has a little bit more of a challenge looking to exit children from foster care within 12 months than the nation on average, but just about at average, and sometimes above average when we look longer than that 12-month horizon. There are a ton of factors that play into those timeframes. Your court schedules, procedures around what has to be done on at what time and in what order. And the work with the families. There's a lot of variables in how those timeframes play out, but it's just important to know what the data tells you when we're thinking about cost. Another way to look at that might be you have children entering the system and you have children exiting the system. So just like, I checked out of a hotel this morning. How many people are coming into the hotel? How many people are coming out of the hotel? You want that ratio to be at 1 if you think the size of the system is appropriate, or below 1 if you think that there's too many kids in foster care and we need to reduce the population, right? That would be the way to look at the data. The national average is just about at 1. Georgia's just about at 1. So Georgia looks like the rest of the country in this regard. Where do people live while they're in foster care? If my child went into foster care, I would want my child to stay with my sister. I would want somebody to license my sister because my children know my sister, they know their cousins, or now they live in a different state than me. So my other option might be, I might want my neighbor down the street who has a son my son's age, and they know the dogs, they know the kids, I might want them to go there so they don't have to change schools. I would not want them to go and have to stay with a family that somebody else picked out for them. Kinship care gives us that option to find out, is there an aunt, a cousin, a basketball coach, a teacher, a family friend, somebody that these kids are already familiar with, so they don't have, that's one less thing that's going to be so hard for them that day that they get placed, into this system. It turns out to also be better for kids, like when you look in the data, not just on an emotional level, but a review of over 100 studies that I think Casey did showed that the use of kinship care promotes more stability in placement. So if kids are in care, they're not moving around from one home to another. They have lower rates of re-abuse or institutional abuse, and they have better behavioral health and mental health outcomes. So these are all way better for children and how they're developing. It's also not incurring some of those costs that are associated with longer stays in foster care because we haven't set up the situation that causes those symptoms to grow, if that makes sense. Okay, what's the next one? Group care. Group care is the least desirable place for a child to experience their childhood. There's a lot of research on this, which I won't go into in detail, but we can supply it if it's of interest to you. Both Georgia and the US overall have continued to reduce their reliance on group care, and Georgia is performing just like the rest of the country in this regard. Okay. I'm going to turn and look at supply side for really quickly, not too much time. I put 3 factors here that influence supply. There's a lot more than that, but just 3 to consider. One is, we're all painfully aware, inflation itself, right? So this is a chart that says, what if there was a contract for a particular service that had a value in 2010 of $100,000? By 2020, in order to be the same value, the price tag on that contract would have to be $118,690. That's what the chart says, right? And today, that contract that was set at $100,000 in 2010 would have to be at $153,000. And that's to do with the pace of just inflation, right? Why does that matter? Well, a vendor, let's say today they were still being, it went out at $100,000 in 2010, and they're still getting paid $100,000 to do the same thing. They just absorbed a 35% reduction in their contract. Or you could make it more recent. If you said it was $100,000 in 2010, I'm sorry, 2020, the point where the slope starts to really go up. If it was $100,000 in 2020, and they still only had $100,000, they just took a 22% cut. That's just math, right? The organizations providing social services, even if they're nonprofits, and most of them usually are, would need to take a significant action in order to manage their bottom line in recent years, just like any other enterprise. I worked on the provider side, so in my experience, some of the costs that I think about when I look at a chart like this would be how are they going to afford the cost of health insurance for their staff? Because those health insurance costs are also going up. I would be worried about the cost of fuel, and if they have to provide transportation or if they have to drive themselves to get from point A to point B. I would be worried about the cost of food if they're providing a service where they need to feed children. These are all their inputs into their kind of own bottom line, their ability to meet their payroll and provide the service. They would have to do one of two things. They would have to increase the price, or they would have to cut back on services. Those are kind of the two options. Just like a restaurant can stay in business and increase the price of the menu, they can stay in business and reduce how much they're offering on the menu, or they can close. Those are kind of the basic choices available. So thinking about our supply side, that's putting supply pressure on, right? If somebody's providing some kind of service and all these inputs are going up, it's hard. They have some decisions they're going to have to make. This one makes me look like I'm real smart and I know what's going on in this chart, but I just cut and paste it from the Bureau of Labor Statistics because I'm not an economist. But I chose it because it shows you something that I think is interesting. That dark blue line that's real squiggly, but it starts out below the green line on the left, and then it comes to the top on the right, that dark blue line. That is the volume of job opening rates in the health and social sector. So that's our sector that we're talking about. There's a lot of jobs available. That could be great. But we got to think about, are there enough workers, qualified workers, to take those jobs, right? Why is there that volume of jobs in this sector? Thinking about this as the care sector. People are living longer. So we need more people doing care for geriatric care, nursing homes, all that kind of stuff. There's a ton of demand in that sector. It's still the care sector. So if you're a person who wants to do direct care services and you've been doing it in children's residential care, you have a lot of other options now for jobs because there's a lot of jobs opening up in a different sector, still care, still direct care, but a different end of the spectrum. Same thing with nursing or any other thing associated with that. People are seeking treatment more often for substance abuse disorders, mental health disorders. So that's driving demand for those kinds of specialized care and treatment as well. But at the same time, the baby boom generation is retiring. So there's some demographics. That is an enormous generation, and the generations behind it are smaller. So you're going to have a big exit from the labor force. So you need more jobs opening up because we just need more jobs, right? We need more work to get done. But you also have jobs opening up because of retirements. So that's a factor in this sector too. So are there enough qualified workers available to take all of these jobs? Well, it kind of depends. And this is a very large discussion to have with somebody else who's a labor specialist and not with me. But I'll just point out that around the country and in Georgia, I checked, there's a severe shortage of child and adolescent psychiatrists, for example. The Health Resources and Services Administration, HRSA at the federal level, tracks the availability of behavioral health care workforce pretty closely. And their latest projection is that as a country, talking about mental health counselors, even though we have 150,000 licensed mental health counselors today, by 2038, so in about a decade, we will only have 55% of the mental health counselors in this country that we need for the demand that's going to be there. That same report says that we'll only have 30% of the addiction counselors available that we need for the demand that's going to be there. So there's a lot of job opportunity, but if we look at are there enough people ready to take those jobs, those questions that are there in red tell us about the pipeline. Are we preparing, are we talking to high school students and college students about how amazing and impactful this work is? Are we incentivizing them to choose these fields of study and go through the licensure processes and enter into this labor market? Are the job conditions attractive? If I can make more money at a less stressful job in retail compared to this kind of work, why would I choose this kind of work, right? So there's some factors, around the labor supply that impact the supply of the services altogether. Another one is liability insurance. This is another, there's so much to say about this, but I put on there an image from a report that if you're interested in this, I would encourage you to read about this is providers reporting out the challenges that they're facing in obtaining liability insurance. Most places require that providers have liability insurance as a condition of being able to have a contract with that public system. But the cost and the availability of that kind of insurance has really changed in recent years. In that study, which was about the difficulty of obtaining it, about the overall insurance environment, providers reported consistently a lot of difficulty in even obtaining liability insurance, that carriers are not willing to offer it to them. Some of them said that carriers actually advise them to stop doing this kind of work because they're just not going to be able to have insurance. The premiums have gone up quite a bit since 2019, and they're rising not because that organization did or didn't do something wrong, or because that organization does or does not have any particular kind of risk. They're going up because the litigation environment has changed a lot. In these changes in statute of limitations around being able to bring an action forward have gotten longer. So just the exposure to a lawsuit has also gotten bigger. The payouts are really large. And there's actually some reporting recently about venture capital interests being entwined in some of this in terms of looking at those large payouts and looking for litigation opportunities in order to obtain a large payout. So it's a complicated area, but matters a lot when we think about the supply of services. So at the top of this discussion, I propose that the most important question for this conversation this morning is what outcomes you want for Georgia's children. And then I promise to provide you an overwhelming volume of detail about things we might want to consider in thinking about that question. Hopefully I succeeded. But to zoom us back out again, what are the outcomes that you want for your neighbors and your own families and people in your house of worship and so on? The charge that we saw to the nation's child welfare system gave us part of an answer to this, which was that the mission that children can depend on their parents to provide them with a safe and loving home. So if that's what we want, some of these tactics on the left can help us to get there. They happen to be the things that will promote good outcomes. They also happen to be more cost effective as well. And there's federal financing match available through things like the Title IV-E of the Social Services Act, the Family First Act that amended that to provide federal match for prevention funding. The ways that you use your Medicaid and other benefit programs in the state, those can all be designed intentionally to promote these kind of outcomes. Okay. Hopefully you're still awake. I didn't bore you to death, but thank you for the opportunity to provide information. I hope it was helpful to you.
Thank you so much. That's great information. Thank you for setting the baseline so that we all are on the same page about what's going on across the country. We have done some work, legislative work, as a result of some of our previous committee meetings, and you guys testified in those too. One of them was putting a shot clock. We call it the shot clock bill, Senate Bill 401, to try to decrease the amount of time to permanency. And what we learned is that we didn't have good data from around the state. And so we funded that. And I think we're almost done with that project. So I think we'll see some changes there. We also passed lawsuit reform last year. And part of that was TPL disclosure bill. That was Senate Bill 69. So little by little, we're chipping away at some of the things that you pointed out. One of the areas of concern, I think, among all of us is the CHINS process, which is the Child in Need of Services, because they don't really fit the criteria that you outlined for abuse and neglect, and yet they frequently end up in state custody. So we may need to take a look at that statute and the way it's worded. If you're good, we can open it up for questions from the legislators on the committee, if anyone has any. Okay. Who's number 6? Is that you, Mayor Margaret? Go for it.
Thank you very much for flying across the country. Y'all are the experts nationally recognized and very grateful for your time. You mentioned Families First at the end of your presentation, and as I look at that data that's published, Georgia has not received any reimbursement, any application for that source of funds. I want to know if I'm right about that.
I don't know. I don't have the information about state by state reimbursement, so I'm sorry.
Madam Chair, that's something that I'd like to figure out a way to get answers. If we have a funding source we're not using and not in compliance, I'd like to know that. Thank you.
We'll be hearing from DHS next, and so hopefully they'll be able to help us with that.
Thank you.
Thank you. Okay, Senator Albers.
Thank you, Madam Chair. Oh, there we go. Thank you so much for your presentation. It was very thorough and thoughtful. Can you tell us, who's doing this the best? What are the 3 to 5 states that are just the shining star and have figured this this puzzle out?
The financing or children in care?
Yes.
Yeah. I wish I had the answer to that. This is really hard work. It's hard work. The thing that comes to my mind always thinking about this is a quote from Tolstoy. The opening line of Anna Karenina is, "Happy families are all alike, and every unhappy family is unhappy in their own way." This is a system that has to be available to meet all of that. And it's a lot of custom design work, so it's really challenging. There are states that have more or less use of foster care placement. The state where I live, New Jersey, has the lowest use of foster care in the country. There's a lot of prevention services and the behavioral health care system around that. It's expensive. So there's sort of those kind of trade-offs. It's a complex, I'm giving you like a waffly nothing answer, but it's hard. It's just a hard dynamic. And I don't know that I would call out somebody as having gotten the brass ring or something. It's hard.
Okay, so we want to be our own North Star. We're not trying to follow anyone.
You do. I think that's right. I think that's right. Every state is different. Every state statutes are different. Your communities are different. Your history is different. How all those other systems around child welfare function are different. You have the opportunity. Why don't you be the first? Show them how it's done.
Thank you.
Representative Gullett.
Thank you. Thank you for your presentation and information. One of the things that stood out to me, I think, was related to the chart of how long a child is in care. I saw in Georgia 31% leave within 12 months. I think that's better than I've seen. I know that's true. But 1 in 5 stay in care after 3 years. And I imagine they're usually the most difficult children. I'm just speculating. For whatever reason, they're not they're not easily adoptable. They're not easily, they have issues that are probably costly. And so is there a cost range of that you could say or speculate on? Obviously I think you're a reunification person. That's like this just from reading into what you're saying. But if a child's there 3 years, they probably have some issues they haven't, but just have some issues that we're working through and need help through. So is permanency faster a better answer if reunification faster is not possible? Does that make sense?
I think so. I think I understand the question. Federal law requires that reunification is the first goal, and federal law gives us some timeframes around that. So I think it's not about that gives us a parameter within which to try to operate. If we have a situation where a lot of children are staying for a longer time, some good questions to ask might be about how are family finding efforts set up during the investigation process so that we don't have to struggle to find relatives for them to stay with or to be connected to. What does the treatment situation look like? What is the age range of kids in care, and what's the availability of supports and services for them to keep them safe and stable so that their behaviors don't get exacerbated? I don't know that there's a general, it should always be this way or it should always be that way beyond these principles that guide us. They're sort of best practice principles in social work and child welfare work, and they're also the law. So that's what comes to mind in response to your question.
Okay, thanks.
That's all the questions we have at the moment. So thank you very much. Hopefully you guys can stick around because there may be some other questions offline later. Thank you so much. Next, we're going to ask our representatives from DHS to come forward. The names that I have are Melody Debussy, Melissa Barwick, and Audrey Brannon. And after their presentation, we're going to take a 10-minute break, just FYI for the committee. Committee members, look in your folders and see if you have a presentation from DCH, because we had a little printer issue today. And if you don't have it, let Daly know at the break and we'll make sure you have it. Thank you. Okay, you guys can decide what order to go in, and you have the floor. Thank you for being here.
Thank you for having us. Can y'all hear me?
Speak
Okay,
loudly.
a
We
little
have people
louder.
on Zoom.
Okay. Well, good morning, Chair Kirkpatrick, Chair Camp, everyone here on the committee. Thank you for having us. My name is Melissa Barwick, and I am the Assistant Deputy Commissioner for Finance at the Department of Human Services and the CFO for the Division of Family and Children's Services. I'm joined here today by Melody Debussy, who is our Chief Policy Officer, and Audrey Brannon, who is our Placement Services Section Director. And hopefully Melody will hit me if I start talking too fast. I'm usually used to sitting behind people who are good at speaking. So I ask for y'all a little bit of grace, but we'll jump in here and get started. So first, we just have an overview of the Department of Human Services. Is it working? Nope. Is there a trick with the PowerPoint? It's just not. Nope. Okay, good. Perfect. Thank you. Okay, so the Department of Human Services delivers a wide range of human services designed to promote self-sufficiency, safety, and well-being for all Georgians. Our mission is to strengthen Georgia by providing individuals and families access to services that promote self-sufficiency, independence, and protect Georgia's vulnerable children and adults. So before we jump into the out-of-home care budget, I did just want to briefly talk about the other program budget where we fund the majority of child welfare services in the state, which is our child welfare services budget. So the budget for staff and admin so our caseworkers, training, prevention services, all of that is housed in child welfare services, where our out-of-home care budget is strictly payments, either per diems, foster care maintenance payments, or subsidies for children placed out of home in either a foster care setting or guardianship. So this budget, 538 million, about half of that is state funded, and that supports 284 state office employees and almost 3,000 county office employees, which includes our foster care caseworkers, child protective services caseworkers, and all of our state support units. You can go to the next. So before we hop into the out-of-home care budget, we did want to just kind of talk through some child welfare statistics. So you can see on the left that we receive about 125,000 child abuse intakes or reports a year, and you can see that that has remained pretty consistent going back to 2018. However, on the right side of this slide, at children in custody, you can see that both the number of episodes of children in custody and those unduplicated numbers of children has decreased over time since 2018. And we credit this to the prevention work that we do, and that we have the same number of calls, same number of reports, but we're bringing fewer children into custody and hopefully meeting those children's needs before it gets to that point. And then I did want to point out to the next slide. So the number of episodes unduplicated children here is higher than a number that you may be used to seeing. So you see it's about 14,000. On the next slide, this is maybe more familiar, is the number of children in custody on the last day of the month. So this is a point in time count, whereas the previous is kind of capturing the movement, right? So we have kids come in and out of custody every day. It's not the same children on the first of the month as it is the last. So I just wanted to kind of show you what we're used to. And this is kind of staying flat, but showing that there's a lot of movement that's happening that maybe isn't captured by this graph. Okay, we can go to the next slide. So this is the out-of-home care budget, which we have 3 sub-programs. First is family foster care, which is funding for DFACS foster homes, placement with relatives and fictive kin, guardianship subsidies, and this also includes our child and family assessments, which have to happen for every kid that comes into our care, and our wraparound services, which we'll talk a little bit more about in the next slide. Second, and this is our largest kind of bucket, is the room, board, and watchful oversight, which is pays for per diems or foster care maintenance payments to child placing agencies, CPA foster homes, and child caring institutions, CCIs, aka group homes. And then smaller bucket, but also very important, is specialized foster care, which is funding for, so again, per diems or foster care maintenance payments for DFACS foster parents who have taken in children with medically fragile children or supporting large sibling groups. So you can see the largest sub-program in terms of funding is room, board, and watchful oversight at 295. But our biggest cost driver, especially the last few years, has obviously been wraparound services, and we've discussed this. Next. Okay, so wraparound services is our contracted services for behavior aids and supplemental supervision, transportation services, counseling, therapy, health-related assessments, crisis care, and more. We manage the delivery of these services through our Delivered Services Unit, which was created in 2015 after foster children moved into managed care Medicaid. And I think that this slide, I just kind of wanted to visualize for everyone not only the growth in the overall need for these services, but specific categories that we've grown in, especially since our aggressive push to end hoteling in 2022 and 2023. So obviously the biggest buckets that you can see here are that dark blue at the bottom, which is behavior aids and emergency supervision, and then that lighter blue on top, which is transportation services. And then I didn't specify on here, but just for y'all's note, the other in this chart includes court appearance and testimony, crisis intervention, preventive family supports, and summer safety and education enrichment. So it's kind of a wide span of things. Okay, so wraparound services is our contracted services for behavior aids and supplemental supervision, transportation services, counseling, therapy, health-related assessments, crisis care, and more. We deliver manage the delivery of these services through our Delivered Services Unit, which was created in 2015 after foster children moved into managed care Medicaid. And I think that this slide, I just kind of wanted to visualize for everyone not only the growth in the overall need for these services, but specific categories that we've grown in, especially since our aggressive push to end hoteling in 2022 and 2023. So obviously the biggest buckets that you can see here are that dark blue at the bottom, which is behavior aids and emergency supervision, and then that lighter blue on top, which is transportation services. And then So I'm going to go back real quick one more time. So as you can see, this has been a big cost driver, and it's been increasing kind of steadily, at least since I joined the team in 2022. So last year, so now we can go, kind of seeing this continued growth in expenditures, I wanted to look at, well, what have we looked at the last 13 months? And so that's what this chart is. Because as y'all know, last year when we were projecting this such a large deficit driven by these WRAP services, so in October is when my team would do budget projections. And so when that was completed in November, as you can imagine, my team raised the alarm that if spending continued at this level, that we would be facing up to an $85 million state funds deficit. So as such, we at DFACS put out the deficit reduction memo in late November, but we didn't really start to see the impacts of those changes until about February. I do want to note that our 2026 base budget was lower than what our 2025 expenditures were. And so when we entered 2026 and we were not able to reduce our projected expenditures to meet that budget, we did have to try to do something to control costs as much as we can or could. One of our initial attempts to manage to that annual operating budget was a change in how we pay external transportation providers, which was proposed in July. Unfortunately, that was delayed due to partner feedback until about October. And at that point, that change alone would not be enough to meet the need of the deficit reduction. And so we had to put in some additional strategies that had to be implemented. So those are listed here, but so mainly kind of making sure to ask parents to use their insurance for services for their children, apply to Medicaid where they were eligible, go to their local community service board, local Department of Public Health office, or federally qualified health center for services before DFACS step in and paid for some of these services. We'd also check case plan compliance to make sure that permanency was not being delayed by asking for those for that assistance from parents. Also made sure to align DFACS case plan recommendations with what fixes dependency, which caused the child's removal, insisting on timely court orders to maximize federal funding, case manager compliance, and shared accountability, and then asking our providers with higher per diems to assist with transportation, visitation, respite, and et cetera. I did just want to point out, because this is kind of a dramatic drop, right, that we see in expenditures for these wraparound services. Our goal is not to reduce wraparound services to zero. There's always a need for these wraparound services. They help maintain that placement and push that child and family towards reunification and a permanency. But the goal is to look more closely at cases and see where we may be overusing services that are duplicative or that are not appropriate for that case. And that we believe that this has helped us more effectively serve our population while being good stewards of the resources that we do have available. Oh, and then we do have, so I think that we've discussed this with some of the members here when we were here for appropriations last year, but we have, the big thing that we've been doing is kind of making sure that all of our service authorizations are going through state office, or most of our service authorizations for WRAP services are going through our state office. The exceptions to that, where we're still kind of business as usual, is transportation for a child to a court or a panel review, the child comprehensive child and family assessments, plan of safe care, DNA testing, the interstate compact on the placement of children evaluation and related drug testing, kinship evaluation and related drug testing, provider and expert court testimony, certified drug screen results for court evidence, and drug screens for CPS investigations to address safety concerns. So I think our government affairs team can provide that list to y'all if they haven't already.
Yeah, you blasted through.
Yeah, I would.
So if you could send, that'd be great.
Please. Okay, now I'm going to pass it over to Melody.
Thanks, Melissa. I'll briefly touch on some of the data behind our recent costs when we look at the children in our custody. As part of an audit request from the House that should be released shortly, and I know you mentioned it at the beginning of the meeting, I use the same data here that we sent to them for consistency on custody over the past few years And included here fiscal year spend from 2023 to 2026, so that period after we started looking at the cost drivers that Melissa just mentioned. This figure displays the cost trend across each of the last 4 fiscal years of that room board watchful oversight and delivered service costs. So just those 2 components are largest variable buckets in out-of-home care by the child's age today. But by the fiscal year, the expense incurred. The added dimension here is a case record flag that indicates mental, behavioral, or neurodevelopmental disorders, sometimes in Medicaid referred to as an F diagnosis, to parse out costs. This could include a diagnosis such as bipolar, autism, or anxiety disorder, and wanted you to see this example. My impression of this data is increasing costs for older youth with case flags to indicate a mental, behavioral, and neurodevelopmental disorder, and lower costs and fewer case flags for younger children. This aligns both with some diagnostic requirements. So there are many parameters the clinicians, and Audrey is one, can tell you in terms of when a child can be appropriately diagnosed with some of these clinical presentations, but also with the behavior presentations and higher needs that drive costs in older youth. The general curves across fiscal years are the same, with some variations due to things like children reaching permanency during this period and some rate changes that may have impacted what ultimately the department paid out between 23 and 26. Our spend in 23 was highest for kids that are 20 now, so it would have been 17 at the time when the cost was incurred in 2023, with 61% of the total RBWO delivered service costs in 2023 spent on kids with a case flag for mental, behavioral, and neurodevelopmental disorders. The trend of that 17-year-olds requiring the highest cost for the children in our custody holds true in 2024 and 2026, and essentially tied in 2025 with 16-year-olds. My impression of our school discipline data, transportation data, and behavior aid data is the expenses needed to maintain school supports and the impacts of alternative school attendance support in these trends, the obviously clinical needs that we know from the case flags of, again, the mental, behavioral, and neurodevelopmental disorders is driving higher costs. Next, we'll talk about the total cost. Over the audit period, 23 through 26, that out-of-home care and DFACs have supported. I wanted to share with the committee my impression from the data that displays their current ages. And as you can see, the green indicates, again, a mental, behavioral, and neurodevelopmental disorder, with the highest cost age group quickly approaching adulthood and aging out of the DFAC system, even with extended supports and independent living programs. I want to pause here because when we talk about the medical needs, community supports, and the wraparounds that these children need, my impression from our data again displays that children in the child welfare system today are hopefully reunifying, being able to reach permanency, and being put on a better trajectory for the supports and services that we're meeting. But they very well likely may be aging into the communities with clinical needs largely addressed or unaddressed, unmanaged, and needing additional supports that will continue to follow them even outside of their case management support from DFACs. Finally, I wanted to share some of the latest data I've explored for children that had a payment transaction in July 2026, so very recent, from a hotel stay. Children that had an emergency placement in a hotel with a payment in July 2026 came from 24 counties. They're urban, they're rural. They represent all areas of the state and are comprised of all of the types of urban centers and rural areas. While DFACs works all available levers to minimize hotel stays, and you'll hear, I think, a lot about that in the audit report. We can certainly go into the efforts the department has taken to minimize that. These no placement unavailable denials leave me with the impression from the data mining I've researched that their overall stays, episodes, and placements display the challenge of larger unmet clinical needs. These children experience hotel stays for crisis. They have runaway and jail episodes and even some YDC stays. They are moving, as the previous speaker noted, through multiple systems and agencies within our state. These children continue to experience, and this is not all of their placement stays, I want to be very clear, they also have lots of episodes in DFACs homes, they have lots of episodes in kinship placements, but they are oversized showing up in some of the places that we most likely know that they need additional supports and challenges. The department needs assistance and collaboration from other agencies and communities to support. This is difficult data to examine and much more complex to fix than any one agency collaboration, vendor partnership, or technology tool. I hope by sharing my impressions with you today that you'll see the importance of the parties on this committee external to DHS and DFACS have for the well-being and future of children in our custody today. In each of the past 3 graphs, I do want to note the green was denoted the case flag record that indicated again that mental, behavioral, and neurodevelopmental disorders. Last fall, I drafted and worked with DCH on a grant proposal to CMS as part of a state plan amendment submission that addresses the needs and fills gaps. It's a partnership that we're looking forward to, and I hope to share more details on how we hope to work together to make an impact on Georgia's children in foster care. And I'll pass it now to Audrey Brannon. Oh, sorry, actually I won't. Real quick, this is data on our medical treatment appeals. We talked a lot about the medical needs that these children meet by the green flag. I did want to note that when the department works with the predominant care management organization that serves our children in Medicaid that come into custody, that many times we have a unit called Health Law and Policy that deals with denials, discharges, and decision appeals. In state fiscal year 2026, that unit filed 803 administrative appeals directly to our care management organization. Those were predominantly, or I would say of those, 149 represented the highest level of care, denial, discharge, or decision appeals in psychiatric residential treatment facilities, psychiatric inpatient, and crisis. And then of those, if we still on a kind of that administrative appeal don't get a favorable decision to the department or to the needs that we think their children are experiencing, we've requested and made 229 fair hearing requests. Of those, 119 were for PRTF, inpatient mental health treatment or crisis. As part of that process, sometimes we get recoveries for settlements. So far, the department, and those tend to lag, so these aren't so we still have lots more that we have are pending, but so far we've recovered 1.5 million back to the state for settlements based off of clinical care. So now I'll pass it to Audrey Bannon, sorry.
Thank you for allowing me to be here today. So I've had the pleasure of being here a couple of times. My name's Audrey Brandon. I'm a licensed clinical social worker. I've been with DFACS for 24 years. So all of my adult life. Right now, DFACS has about 9,300 kids in foster care, and my job at DFACS is kind of the hardest of the hard. So the kids that nobody at the department knows what to do with, both creating individual case strategies and systemic solutions for those kids. Those kids tend to be our high cost drivers. So one of the things I'm going to do today is talk a little about just 2 examples from like the past 2 weeks. And really this week, there are some people on this committee who have gotten emails from me this week about these kids. And you know, the hardest part of working in this system is when you care this deeply about a system that cannot meet every single need. Caring deeply while every single day, right, being told or expected, court ordered to do more, to do the impossible, to find solutions that no one else has a solution to get kids out of hotels, but don't spend too much money doing it, keep kids safe. At the same time, group home staff are getting physically assaulted, property is getting destroyed, people are being injured. We also, right, are asked to hold providers accountable for outcomes, but not all the providers and not in certain ways. And at the end of the day, my biggest job is to ensure kids are placed safely when there are no placements. So a lot of times there are other organizations that can decline these kids, right? They can say, we don't have a bed. They can say, we're not going to put this kid on probation. We're not going to detain this kid. We can't enroll this kid in waiver services because there aren't enough slots. We don't have a waiver service place to put this kid. There's not a classroom available that can meet this kid's need. And that's when they call us. When their systems can't serve a kid, they call the Department of Family and Children's Services. You know, over the past year or so of my career, I have had leaders at every level of every organization, from Department of Juvenile Justice, Department of Community Health, school systems, state school system, special education employees, say to me, there aren't enough resources for this kid. They're going to need to come into foster care. Not because they're being abused and neglected, but because there is not a system that can care for them. So they want these kids to enter foster care. And I've said this before, like it's this magical place. Like foster care is a place. It's not a place, it's a legal status. People think kids can come into foster care and they go somewhere and then they're not the problem of that county, that organization anymore. They just magically go away. And there's some place where there's the perfect treatment facility and the perfect foster home and everything is solved. That's not true. And they place kids in foster care thinking that we have resources that truly do not exist. Last week, someone emailed me and said, well, I've heard that there are some kids that go to out-of-state PRTF, psychiatric residential treatment facilities, and have done well. And I said, okay, can you send me that website or phone number of that facility? Because it's my job to know, and I don't know what facility you're talking about. And I did not get a response because it doesn't exist. So public service has always been my calling. I've spent my entire adult life doing this work. I am passionate about it. We've heard a lot of data today. I bring the real examples because these are the kids that I am calling out my leadership about at night, worried about, and they're kids. They're real people. They're families. I know that there's a lot of discussion about our costs, but at the end of the day, sometimes putting a face to a name and understanding what these kids are like is so important as we think about the system that serves them. So I've changed some details, of course, to help confidentiality. So some of you may recognize some of these kids if I've reached out to you about them. But we have a 19-and-a-half-year-old who, again, he's one of our high cost drivers. He's diagnosed with autism, disruptive mood dysregulation disorder, and he has a moderate intellectual disability and ADHD. His full scale IQ is 40, which falls to the moderate to severe profound disability. So he entered foster care for the second time in 2021. He was 14 at the time. His older brother also has severe autism and an IQ in the 40s. And they both came into care because Nelson's dad could not keep his female siblings safe from his older siblings' sexual abuse. He could not manage Nelson's severe aggression. Nelson had not been in school in 2 years because the school system that they were in kept sending him home because they could not manage his aggression. So with no other option of keeping the other children safe in the home, these boys came into foster care. In the 5 years since he's been in foster care, again, now he's 19-and-a-half. He's had multiple crisis stabilization unit stays, 5 different CCIs, so a group home, including some very specialty programs that we created just for this population. Child placing agencies, he's been detained multiple times at RYDCs and adult jails once he turned 17, which is probably the most devastating thing to me. In the past 2 years, he's been arrested numerous times for simple battery, aggravated assault, assaulting a law enforcement officer, criminal trespass, including several felonies. And again, this is a young man that has a 40 IQ, and he has very severe autism. At one specialty group home that we designed for this population with one of our very high-performing providers, law enforcement ordered that he be removed from the county and never return. At another placement, also designed just for this population with a very high per diem and experts, RBTs or their whole staff, so registered behavior technicians, to serve this population, 6 employees quit in one summer because of his aggression. They felt unsafe to come to work. This young man was then in jail from October of 2025 to June of 2026 with a 40 IQ and autism. After months and months, and some of the people on this committee got my emails begging help. He is in jail. He should not be in jail. And the match committee was very involved. I worked very closely with them. They helped me get him admitted to a match funded program, and he did not last 30 days. He assaulted a female employee. He punched her in the back of the head multiple times, and he is back in jail. He's approved for DBHDD waiver services. He has been for quite some time. They don't have any options for him. He was staffed for consideration for the Crisis Services and Diagnostics Center for Intellectual Disabilities in Macon. They declined to add him to the wait list, and the wait list is extensive. The match committee, again, has been working really closely with me on this kid. There are multiple state agencies involved. No one has an option for him, so right now he sits in jail. If he gets released, he'll be at the DFACS office or in a hotel with probably 3 staff members, 3 behavior aides with him, and hopefully everyone will be safe. And we just don't know how long then he'll be in a hotel. That's a question I get a lot from our leadership is how long do you think? And months would be my guess. The other youth I want to talk about is also 17. So it's interesting that, one of Melody's points was these 16 and 17-year-olds are our highest cost driver. And this young man also has an IQ of 45. He's diagnosed with schizophrenia and autism. He came into care in 2022 for similar reasons. His mom could not keep his siblings safe from his sexual behavior or his mental illness. When I reviewed the record, she made multiple calls to the local community service board. He was in services with them. She was in the emergency room begging for help with his aggression and his sexual behaviors. He was on hospital homebound from school, so he was home all day. Doing a lot of watching of pornography and a lot of screen time as they tried to get him to comply with online school. Now that he's in foster care, he can't be managed at school. He's not been in school in a long time. He requires 2-to-1 supervision. So he is at a placement. We are paying that placement. And because the ratio at most of our placements is more like 6-to-1, 8-to-1 overnight, we have 2 additional behavior aides with him. So we have to pay for that staff. So we have 2-to-1 caregivers with him. They still can't keep him from fleeing, eloping, exposing himself. One time out of nowhere, he punched his 23-year-old female case manager in the face and ran into the woods and was found hours later after a massive search by law enforcement because of his disabilities, right? He has autism and a low IQ. And he was found in a homeless encampment about a mile from the DFACS office and brought back to the case manager who he had just assaulted. She didn't quit, thankfully. She actually went on to get promoted a few months later. So we're excited about that she stayed with us. But this kid is so impulsive and his psychosis is so severe that he has visual hallucinations. He has command hallucinations. He has extreme difficulty concentrating, and he continuously exposes his private parts to females in public, at the group home. He really can't be with female staff members. So when you're talking about workforce, now you're asking for a workforce that is male driven, which is not what we see in healthcare. At one point, he did go to a PRTF, a psychiatric residential treatment facility out of state. They could not manage his elopement and sexual behavior problems. Again, he assaulted several female staff members, both by groping them and hitting them, and they told us to come and get him. And they told us to come and get him immediately and threatened us with law enforcement if we were not out there within 48 hours. So like other youth, he is on the DBHD planning list. They'll consider taking responsibility for him when he turns 21. So we have 4 years where he is going to be under our purview, but then like Melody said, he's then going to be an adult and he's still going to need state care. He is eligible for a now comp waiver, but if he gets one of those slots, it won't be until he's 21. And in the meantime, he'll be in our extended youth services, which is not designed for kids like him. He's going to require adult supervision, probably, like we said, 2 to 1. He is currently, again, approved for PRTF, but neither myself, DCH, DBHDD, the match committee, AmeriGroup, or anyone else has been able to find a hospital to accept him in the country. And I was emailing with my AmeriGroup here last night about we're retrying some of the places again for the 3rd and 4th time for him. So, you know, because of his, again, 45 IQ and then these sexual behaviors, it really has prevented us from finding an appropriate healthcare setting. So I wanted to talk about those 2 kids. And then I did a little of my own layman's data around looking at our highest cost kids. We took kind of the 18 highest cost kids, and ironically, a couple of these kids were even kind of during the 4 fiscal years we looked at were in jails or PRTFs where we weren't funding them. But of these kids, 10 of the 18 had IQs 40 or below. 2 of them, their IQ was so low we couldn't test it. 3 had IQs in the 60s, 3 had IQs in the 70s, and 11 of the 18 had autism spectrum disorder, and all of the others had major mental health diagnoses. So what this says to me, it even surprised me when I looked at it. And when we have kids with IQs this low, they can't go into congregate care. They aren't supposed to live in group home settings, so they need foster homes. We already have fewer foster homes than children, and we're asking more and more of our foster parents every single day. This chart to me represents a lack of community resources. It represents a lack of services for kids with disabilities. These kids came into care because there are not resources for them to be with their families. And they come to foster care in hopes that we have the resources. So what happens when we don't? Even the most resourced family struggles to meet the needs of kids with disabilities. So what happens when we have a fragile family trying to navigate this system? When we have a family that's living in poverty? When I, with a bachelor's degree in social work, a master's degree in social work, and a clinical license, and this being my life career, do not have a plan for these 2 kids. Families can't then navigate that, and they crumble under the pressure. And this is the result. The kids enter foster care. There are high cost drivers. And we all are struggling as a system to meet their need. So I wanted to just bring those examples so that when we're looking at the data, we remember the kids behind them and they're real kids. And again, several people on this committee have heard from me about both of these boys because it wakes me up in the middle of the night to know that they are not getting what they need.
Thank you very much. Just a couple comments, and I know the committee has questions. The match process, you guys are actively engaged in that, hopefully?
Yeah.
Because we, as a legislature, did create that for the exact reason that you're talking about, because we know that these issues go across agencies, which is why we have representatives from every agency on the committee. You mentioned autism. We have done a lot of work on autism and with mixed results because we know that those kids are more likely to end up in foster care, and we will be hearing more about that at future meetings. The question that Mary Margaret Oliver brought up about federal funding, we're going to need to get an answer to that. So I don't know who wants to tackle that one.
I can take that. So this is about the FFPSA prevention funding. It may just be a function that it looks like we're not drawing down because of timing. So prior to the federal fiscal year that we're currently in, federal fiscal year 26, all of our FFPSA implementation for those prevention services were paid for with the FFPSA implementation funding, which is about a $10 million grant that we did maximize over 5 years. Last year, this year, we finished off that grant in the first quarter of state fiscal year 2026 and spent roughly $900,000. And then now that has shifted to a state match with 4E prevention funding. But because we're still in that current federal fiscal year, the reflection of that is not going to be shown until we end this federal fiscal year. I will say that for 2027, state fiscal year 2027, we are planning to spend $4 million on Family First prevention services, specifically functional family therapy, multisystemic therapy, the Intercept program with youth villages, and parents as teachers. And we're also, I believe, looking into increasing or adding a new service for medication-assisted treatment. So I'm happy to send that information to Amber, whoever on the committee, with the exact numbers, but
Yeah,
we are
send it to
actively
Amber.
implementing. Yeah, okay.
Yeah, okay. Did that answer your question?
I understood about a third of what you said. I would like follow-up. When the federal documents show that there's absolutely no money coming, it raises questions. And so
A different funding source. So it wouldn't be reflected on that document because it's a different grant. But next year, when you pull that document, when we close out this federal fiscal year, I promise you will see expenditures.
I'll be happy to follow up with you specifically on this question. Thank you, Mr. Chair.
Oh, and then, yeah, Melanie.
Yeah, high level. So one of the things I also do at the department is apply for grants, competitive grants of all sorts. We have a grant that we're submitting probably Friday or Monday. That's the ACF Title 4E Prevention Accelerator Grant. Part of the reason ACF is offering this opportunity to states is because all states are having challenge with accelerating our prevention services. Our application or grant proposal that we're submitting is aligned with terms. It's going to implement the 2 services on the approved 4E prevention plan, BSFT and MOUD, which Melissa talked about. BSFT provides that short-term intensive home-based therapy for youth ages 6 to 18 and addresses substance use, behavioral concerns, and mental health. MOUD is the medication-assisted treatment for substance abuse. So both of those things will be part of our accelerator grant proposal. And we hope we have a strong proposal, and we have been successful with grant proposals in the past. And so I'm hoping that ACF will look on this one kindly. And I know the team is ready to implement as soon as they award.
Thank you.
Hi, my question is for Ms. Brannon. You testified that a lot of these kids in foster care should never have been put in foster care. Out of the 9,900 that are in foster care, approximately how many are those?
I don't know that I can speak to a number. That's some information we can get you about the removals. It is just overwhelming the number of kids that come into care that come across my desk that end up in hotels and are high end because of their aggression and a lack of services and the safety risk that the kids pose to the family versus the family poses to the kid.
Okay. And of the 18 most expensive foster youth costs, how many do you believe are not appropriate for foster care?
$12.
And has DFACS appealed the order on those 12 to a higher court? Because I assume a judge is the one who is sending these kids to foster care.
Yes, or the parents are at the point where they say, I cannot keep my other children safe. So it's not always a, bench removal, right, is the term we use. Sometimes we are requesting custody of those kids because the parent says it's the child abandonment kids, right, which we've talked about here before. They're at CSUs, they're at hospitals where parents say, I can't do it anymore. This kid is assaulting me. This kid is assaulting my other children. I've lost my job. I've been evicted because of this child's needs. And so I can't pick them up.
So you're saying those kids are going before a judge and the judges are telling you are ordering you. And about 12 of those out of the 18 are judicial referrals.
No, I'm saying of the 12, I don't think they're appropriate for foster care because it was not due to parental abuse.
Okay, isn't that a decision the judge makes? I mean, nobody
is.
just goes into foster care
Right.
without a judge making
Yes.
a decision.
Correct.
And so these judges have determined how many have defects appealed of the 12?
I'm not sure. I can get that information. We do have an appeal process. We work with our SAGs regularly when there is a bench removal. But what happens with these kids is that a lot of times, again, if the parent is refusing, then there are grounds for dependency. So we are filing petitions. But again, they're refusing because of other safety factors, that if the child had appropriate mental and behavioral health treatment and support in the home, if that service was available and existed, they could be maintained at home. But there's not a service provider within a 3-hour radius. And so the service isn't there. And so then the child gets abandoned at a hospital or at a court hearing. Absolutely, that happens. And then the department is then forced to file a dependency petition because at that point, that child is dependent because the parent's refusing.
Right, that would
Yeah.
be neglect at that
Yeah.
point.
Yeah.
Which is an eligible reason to put somebody in foster care.
Yes.
Okay, and how many, you think all 12 of those were abandoned or didn't, maybe not initially have a reason for foster care, but ultimately a petition for dependency was raised, and so they were eligible for foster care at that point?
Yes, they were eligible.
Okay, so ultimately, whether it's from the beginning of the case or not, or later on, these kids are meeting the criteria for foster care, right?
Yes.
Okay. Thank you.
I think one note that could be helpful in that is when we think of the primary goal for reunification. I think as the speaker from Casey spoke to, what is reunification? And I know when we try to reach permanency, and you saw where Georgia lies in relation to the national average on permanency, what does that look like for that child when we know that the best outcome is to rehab first reunification? And if not, then other permanency outcomes are something that that we are obviously looking for, right? So adoption, other types of options if reunification can't occur. But in those instances, I would say the cases that Ms. Brandon is raising, it becomes what is, and I think the speaker from Casey raised this, what is the outcome that you would like to see for what a permanency outcome looks for that child who will not be able to reunify with that family, the adults have said that they don't have the capacity based off of supports and community to care for that child, especially with the considerations of the other children in their homes. I think those are things that we are weighing as we look at how we deliver the total system and structures in coordination with other agencies in the state to serve these children.
Precious, sorry. Thank you all for being here and for your presentations. I had a question on page 14, so I guess it would be Ms. Brannon. So you talk about the 18 of the most expensive youth. Tell me what it looks like that 2.1 million. Is that an annual cost? Is that the cost over the life of the child being in care?
I can tell you real quick about the cost, right? So this is state fiscal year 2023 through 2026. This is their room, board, watchful oversight and delivered service costs only. So there could be other categories of service that I'm not capturing in this total cost. So over 4 fiscal years for this child, the most expensive child in foster care did come in with over $2.1 million based off of their eligible federal drawdown. So for example, I did not do analysis to say of these 18 kids who might have qualified for 4E match and in what situations. Obviously, if they're in a state-funded PRTF or if they're experiencing an other placement cost that is not eligible, a child care institution larger than 14 days, for example, 4E would not be eligible, but in some instances, parts of this could have been paid, especially originally in some of this time period by a federal funding source, but generally this is all the maximum cost.
All right, so the 2.1 on the most expensive child, how much was drawn down federally for that child? Because that's a huge number. And I understand there are going to be instances where not everything is going to be covered, but how much was covered federally for that child?
On this specific child, I believe 0.
Not one penny came down on this child.
So this child, I do not believe qualified for 4E based off of the placements this child experienced during this time period. And I do not believe that there were other federal funding sources like TANF, for example. This was not the beginning of this child's emergency placement. So any type of placement in the initial 6 months when TANF funding would be eligible based off of a 1996 prior AFDC waiver from the state, that also would not qualify. So for those parameters, the timeline of this child and the custody date they came into care, federal funding would not be able to be utilized, but that's something we can certainly run this 18 list against like things like 4E to see what portions of that may have been eligible. I don't want to say no of these children could have had some 4E contributions, but that is certainly not from the basis of their placements what we have experienced. Like a hotel, for example, you would not be able to use 4E in a hotel.
And none of this was Medicaid money, which is federal money.
Correct. None of this is their Medicaid. So these children did have a PRTF stay. Many of them during this time period, if their PRTF stay was authorized and funded by their Medicaid plan, then that would also not be captured here. So this is not the state's cost of this child. This is the DFAC's cost of this child.
Is there any way we could get the state's cost, the holistic state's cost, including the funding?
Department of Community Health for the claim costs paid out through the GAMA system. We recently have been able to work with them to get better data from them. I think the last file we ingested from them was over 1.9 million records. So we'd certainly want them to be confident with the number that they would pay out towards service for this care of this child.
All right. I'm sorry, Mr. Busey. I did not mean to interrupt you.
No, you're fine. This is Ms. Burke.
While we're speaking about federal funding, because it was a point of clarification I meant to bring up earlier and didn't. So our federal funding for foster care is really two fund sources. One being TANF, and that is for initial emergency placements. We are able to do that because of basically a grandfathered in provision in our Aid to Families with Dependent Children plan from 1994, 96. And that again, for 6 months. And so that's an emergency placement. Then that child either, depending on their eligibility, both as a child and the placement that they're going to, could potentially be eligible and receive reimbursement for Title IV-E, which is the main federal funding source specifically for foster care and adoption assistance. I think though it's important that even TANF, which is more like a block grant, both of those funding streams are driven by specific child eligibility and placement situation. It's not that we get a check from the federal government for $200 million a year, spend how you please. There's a very rigorous 4E eligibility process. And we actually just did our, I think, every 5-year 4E audit from the federal government. And we did pass, we were in compliance. So I think we have shared that with, if not this committee, others, and we can get that to you. But I just wanted to make that note. And right now our 4E penetration rate, which is the number of children who are eligible for 4E if they were in an appropriate placement. So it's not the number of kids who actually receive 4E, but the number who would be eligible is around 37%. So it's a minority of our population in care. Free money stuff.
Chairman Dempsey.
Yeah, and thank y'all for the work you do. There's no doubt it's very hard and very heartfelt. I don't know anyone who works in child services that doesn't have a huge heart for children. So a couple of things. I had one question, but then another one may have just popped up, if I may ask two. So first of all, in the costs, in the discussions this past year through the budget, transportation came up time and time again, how expensive that is and what a burden it is, and how that plan and that necessary as well as responsibility of transportation for the child, for services and to be with family members, whether it is a sibling or a parent who is trying to reunify, and we're making sure that that isn't an option or that it is a good option. So the cost, why are y'all seeing it's so high? I know it's pretty reasonable to say placements are far away. Sometimes they're 100 miles and plus more in our great state away from their home, and the foster home is in a very far away position, costs a lot. But what can we do? What is happening with that?
A little bit of that. And part of my data mining, looking at both the court orders that may have specific supervision and transportation requirements to make sure that the child can be able to finish that mandatory, let's say, court-ordered visitation with a parent or guardian. Also could be school. So we're seeing one of the analysis I completed this summer was about school discipline and foster care and how that's driving costs. I would say really interesting situations there when we talk about children, as Ms. Brandon stated, that might be kicked to an alternative situation. And so then the department is trying to maintain their this K-12 costs. And so trying to make sure that we can have transportation there. Also, I would say from a lot of the data that we see, trying to make sure that children, especially with high needs and high clinical needs, can maintain continuity to their providers across placement. I would say, I call it placement velocity. It really just means very high needs children who can't stay regulated in the placement. And so to maintain continuity with their clinical team, we do a lot of transportation. I think a lot of folks say, why isn't that covered under the non-emergency transportation and EMT from DCH? The issue we have there is foster parents and caregivers, a lot of our CCIs, right, they're required to work, which means that if transportation needs to occur for a child to have PT, OT, clinical behavior counseling, that transportation has to occur to maintain continuity, but also an adult has to make that transportation because, otherwise we get foster parents, we hear them say, I'm missing too much of my work. My job is on the line. I have other children that I'm caring for. And so can't make, an hour and a half, 2-hour trip to a clinician to maintain that continuity of care. And we find that really hugely supportive for the child to have the same clinician, whether their placement moves from Conyers to Dougherty County, or they're moving from Hayhira to Brunswick, right? We want to make sure that their psychology appointments, their counseling, all of their autism service disorders, if there's some type of continuity that we can make there, because we think that perhaps this placement might be temporary, or we're still looking for a more longer term placement option. So trying to get that child stable enough to be able to have it closer to home. But also we've been doing a lot of work with Home for Every Child, right? Trying to make sure that they're maintaining continuity with the community from which their case originated. And so a lot of those pieces. So in transportation definitely can give you more specifics. I can tell you more about kind of the geographic areas that we move through. And we have, I think, a lot better data now about where our transportation costs from looking at specific 51856, we call it. That's your CoStar. CoStar is public. You guys can look it up, but 51856 is transportation. And we delineate now more in 2027, 26, the 27 state fiscal year, the difference between if I have to do it for education or another reason. So our codes are also getting better in our record keeping.
Well, and one thing I want to add is like a good example for me is a kid within one provider was placed in a town and then moved about 4 hours away to within the same provider, but to a different location to increase their level of care. And the kid had braces. And in order to keep his braces and taking him to the orthodontist, it's like a 9-hour day. And so we have to pay a behavior aide to be with that kid, plus drive them, plus mileage for 9 or 10 hours once a month. And that's just his braces. So he also visits his mom every week and has to go to therapy every week. And the provider has 7 other kids. And so even when we asked the provider, can you help? They agreed that they would do it once a quarter. Our DFACS case manager is going to do it once a quarter. And then the other 2 times we're going to use a provider. So it's the geography combined with the amount of time, combined with the number of appointments and needs. And these kids are moving sometimes 2 and 3 times within 3 months because of their needs. And again, when we disrupt their mental and behavioral health services, then their medication lapses. They don't have their therapist. They disrupt again because so it creates this churning, which then results in more transportation costs for us.
Well, and I know that can certainly be a deterrent to someone wanting to be a foster parent just because they can't do it. They can't keep their job. They can't.
Absolutely.
do what is necessary. And these are mostly hands-on services that you cannot do with telehealth. I understand that fully. I do think and hope, I know, and it was, I think it's on page 8 where the transportation came up, the other reasons that are driving this deficit. You know, I want to make sure it's asking foster parents to use their insurance for services. Is that what it is? Or
No.
is it asking the biological parent?
Right. So if in court case, a typical court case, let's say a judge orders a parent to go through a psychological assessment, a substance abuse assessment, a domestic violence assessment. These are common assessments we see, and honestly, in the data, more prevalent now than they were even 2-3 years ago. So in those instances, before DFACS decides to make a contribution and payment, honestly, pay for the service to be completed, we'll ask the parents, is this available through your health insurance that you would qualify? The same way I know many, and I know Ms. Rhodes can speak to this from what the Medicaid state plan amendment allows in terms of the psychological services, for example. That initial psych assessment, if their Medicaid coverage or their health insurance coverage qualifies them for the psych assessment, then we'll ask them to use that pathway for 2 reasons. One is cost, but not just cost. We also know that if the parent can find continued support in community using their own resources without the department, they're more likely to continue in being able to find that provider, be able to continue therapy, continue counseling, continue any type of other medical clinical assistance they need if they find it already in the network by which they qualify for health insurance as premise. So we want them also to not have a temporary kind of DFACS gap filler, but then continue to, let's say, have the challenges of their own mental, behavioral and neurodevelopmental disorders, their own counseling needs or other therapeutic needs. We want them to be able to be self-sufficient so that when we find that reunification, they're able to continue in community in a way that is more supportive for them on the long run.
Well, I hope that one of the outcomes as we study this can be to really focus on that, because it is a huge need and a huge challenge as well. And I wonder if, like when you say you're asking the parent to do it, is there a possibility that with our SAGs, there's work that could be done to make that a part of the actual court-ordered plan in cases when possible? I've heard from a number of our SAGs, and I know we tried to, they are right up there next to y'all with people who do really good work out of the goodness of their heart quite often. They are really struggling. We tried to pay them more once again, and that didn't work out. We'll hopefully need to want to go back and do that again. But I know that they are not getting paid right now. They are having huge delays in getting their money, I'm told. I've had calls in the past 2 weeks from many of them
To do more.
that they'll submit their hours and it can be 45 days or more before they get paid. And in the meantime, they're picking up more and more work and trying to make this all work out. So in essence, if if it's June 1 and you file that you've put in so many hours, they may not have gotten it yet today for
Yes,
that money.
ma'am.
What's the challenge? What can we
Yes,
do
ma'am.
there
Let me speak
to keep them on?
Yeah, more to that. So one of the things the state enterprise went through, so the entire state, not just the Department of Human Services, but was a transition to Georgia at Work, our new kind of financial platform off of Teamworks, which was this prior state platform. One of the things that I would say not just our SAGs, but all providers could be experiencing right now are delays as we have to get them registered and appropriately routed for approvals of invoices for their payments. This is something that all state agencies are experiencing. DFACS and DHS are not alone. We're partnering with the state accounting office to resolve this. But as the largest, I think, community exposed, I would say provider network, DFACS and DHS certainly are the space where a lot of those transitions can occur. Additionally, I think we've also had some challenges overall with just ensuring that a lot of our cash flow disbursements continue through this process, that the allotments that go from, this is very in the weeds of budget, Melissa, but from the Governor's Office of Planning and Budget with allotment holds to the comptroller to release the warrants for cash to DHS that then goes to the DFACS regions to then pay DFACS counties. It is a not quick process. Certainly would be, I would say, open to talk to you about streamlining and some of the efficiencies that we would like to see in the financial kind of components, especially from the data side, invoicing, a lot of that process right now, the regional accounting team at DFACS has to really monitor on a very continuous basis. And so that is a big lift. They do it consistently, making sure that services was rendered so that providers can be paid, all while making sure that the caseworker has access to all of the delivered services. I think you'll see this in the audit that is about to be released. But one of the solutions we had, Argo for delivered services, which is specifically not just SAGs, but this space, I think had a different kind of streamlined impact. And also, I would say you're going to see as the audit will show, I think just because our data shows this, some of the Argo impacts. That is something too, in terms of talking more to the Attorney General's office about how SAG invoices roll through, so we can make sure. I think it's certainly something that we can, partner with them to better understand how we can get those payments facilitated timely.
Good. Let's see what we can do for them. Y'all need them.
Yeah, for sure.
Okay, Senator Wicks, and then I have a few, and then we're going to break. And it's highly likely, I'm just guessing, that we're going to ask you guys to come back for another meeting on a later date. So,
Sure.
Senator Wicks.
Happy to.
Thank you, Chair. Thank you all for being here this morning. I just have a quick question. You showed a snapshot of the 18 highest cost. Can you break down the cost difference between the IQs?
I don't have that information with me. I do know on a different list that has identifying information, which the kids are who have the lower IQs versus the higher IQs. But again, 10 of the 18 had an IQ of 40 or below. All but one had a below average IQ and met the criteria for a developmental disability.
So,
But one.
So can you circle back around with us with that information? And then lastly, can you expound on expenses and reimbursements from the federal level?
She did that.
Relative to the 18.
Oh, yeah, we'd have to, we don't have.
Yeah. Get that information. We're going to get the full state costs, including the medical costs, and then look at whether any of them were eligible for 4E reimbursement during this period. And like Melody said, and I know we talked specifically about, right, this highest kid, I talked about him today, and he wasn't 4E eligible. He wasn't in an approved placement. He hadn't just come into care. He has extraordinary needs. So it was very unlikely received any 4E reimbursement.
And just so I think we can go over this too at the next maybe meeting. 4E has kind of 4 tests, right, to make sure a child's eligible. It's what our audit was about from the federal government about our 4E claiming process. And those 4 tests include a component from the court, so that that they have a specific language and an order. And I know we've worked in the past to make sure that that is consistent, but some of our kind of missed 4E has to do with making sure that those orders have required statements so we can qualify.
And that goes back to the appropriateness of foster care. Is that the judicial language specified that this child has been removed for that purpose? Right. Of course, I'm blanking on the language right now. I know.
Right, they meet the standard. Yeah. The other component, I think, just so folks also really understand, is kind of related to the income of the family at removal, and that the child was removed from the family. So, for example, any child that comes into custody and the department claims dependency at a crisis stabilization unit, a psychiatric center where the child is being claimed dependent from another facility, will not qualify for 4E ever. And so the removal specification in terms of where is the basis of where that child was removed has to be from the parent, not the grandparent who might have, before DFACS was involved, maybe voluntary kind of custody, unofficial custody arrangement, but actually that and so there's lots of, I would say, very challenging situations in families that I think that folks might say, hey, we think this should qualify for E, that under the federal requirements, those 4 kind of prongs that we have to satisfy to actually claim 4E makes them ineligible. And so those are factors also that we, on the 4E RevMax side, to claim that, have to make sure that all of those are met so we meet the federal compliance standard for 4E claiming.
Thank you. I have 3 quick questions and then we can break. I don't understand how you can use the parent's insurance for a kid that's state custody.
So we're not using the parent's insurance for a foster child. I think Ms. Barwick misspoke. We're using the parent's insurance for the parent's psychological assessment, if allowed, the parent's
Okay.
domestic violence
Okay.
assessment, if allowed, or substance abuse services, if allowed by their insurance. Obviously, if they have no insurance or underinsured, they have an insurance plan that doesn't qualify, we'll continue talking about the appropriate ability, and DFACS has and is still paying for assessments where the parent has no health resource. But if the parent is on Medicaid, for example, and I hope maybe Ms. Rhodes can talk specifically about this, but the Medicaid benefit that would in certain instances qualify to be able to be leveraged in an instance with the parent needs a psychological assessment as ordered by the court.
Okay. Second question. Do you have any idea what percentage of the kids in foster care now are high acuity, high needs?
So I think Dr. Gibbs is actually in the audience. He did some AFGARS data specifically that talks about the number of kids. So we can get you kind of what an estimate is. I can tell you just from looking at this data, right? So our 2026 data, in terms of this is cost over time. But when you look at like kind of the overall expenses and the actual numbers, I mean, we're talking more than half for sure have high needs.
More than half the kids in foster care are high needs. Is that what you just said?
I think at least if you define high needs as having mental, behavioral, and neurodevelopmental disorders that need to be addressed, yes, ma'am.
Okay, maybe you could get us some more data on
Yeah,
that.
I think one of the challenges that we're trying to make sure that we work with is that the case flags, I'm now making sure, and that's recorded by our DFACS caseworker staff. So in instances, for example, the child might have high needs, but it wasn't flagged in the case record, I can't query that. I'm now bumping our data against the Medicaid claims data, which DCH has worked with us to partner to understand, and using an F diagnosis and the DCH claims data. The challenge there is if the child didn't visit a professional appointment, they call it professional claim for a specific, where the diagnosis was F, mental, behavioral, and neurodevelopmental disorder, it won't show in the data. So I would say we have an ongoing conversation about how to define that.
Okay.
Also, if you want to give us a definition of acuity, then make sure that our response can be better toward what you're talking about. Because I think that language complex, for example, is not a term that DFACS has defined. It doesn't appear in statute.
Okay, and then lastly, I want to just talk about contracts for a minute.
Sure.
Because all of the legislators up here have heard from people about contracts. Unite Us is one that comes to mind because the study committee that we did last year were indicating that the use of a closed loop referral system would be beneficial to the caseworkers, and that contract wasn't renewed. The training contract, I don't remember the acronym. I know there are some provider contracts in play, and it would be really helpful for the committee to have a breakdown of what those contracts were and also how the department's backfilling the services.
For sure. I think we also can speak to the deliverables and our experience with the contracts to make sure that all of that is very apparent and evident for the committee to consider.
Okay, well, I think we'll probably see you at the next meeting. Thank you very much. And we're going to take a 10-minute break. Committee members, be back in your seats, please, by 11:40. Thank you.
Wait.
And I wanted to change the agenda just a little bit because some of our judges have to get back to court. So I've asked the representative from the Council of Juvenile Court Judges, Judge Allison Toller, to come forward, and you guys introduce yourselves and you have the floor.
Thank you. I'm Allison Toller. We am a juvenile court judge in Hall and Dawson counties, the Northeastern Circuit. We also have Monica Wilburn from Houston County, and also with us today is Heather Dunn from Forsyth County, and representatives from the Council of Juvenile Court Judges. And we really wanted to thank the committee for having us here, giving us the opportunity to speak and to answer any questions to the best of our abilities that you may have for us. I also want to thank Casey Family Programs, who hit on a lot of the topics that we were going to address. So I'll try to skip through those that have already been covered. And just to explain, I did a summary in our PowerPoint of a white paper that we presented. So you have a very long 11 or 12 page document to read at your leisure. I'm just going to try to hit the highlights of that today, so there's not a corresponding PowerPoint. And also, just kind of as a aside, we are 3 judges representing 3 counties. I think our experiences are vast throughout the state. What one circuit experiences might be very different than what another county experiences. So we tried to get input from all of the juvenile court judges, and that's contained in the white paper. And we just continue to desire to problem solve and collaborate with our community partners to address any issues however we can. So I'm not sure. Okay, here we go. So I'm just going to talk about kind of what we experienced when I'll say kind of before and after November 2025. Again, this is from the juvenile court perspective. And I know your central question is, how can Georgia control costs without reducing child safety, permanency, or well-being? So we're just going to try to address what changed, what we think the current status is, and what strategies we've thought up to try to help with costs. So Georgia law provides for regular judicial oversight of dependent children. I think one of the most impactful legislations that y'all have presented was in 2013 when you changed the code and gave every child a interest-driven attorney. We also have guardian ad litem for all of our children, whether those are served by CASA or attorney guardian ad litem. And I think that has really helped permanency because you have a child advocating for moving the case forward, moving quicker to reunification, moving quicker to adoption if the department hasn't filed a petition for termination of parental rights. So that's very important. And dependency cases have a very strict timeline, and I presented that as an appendix to your white paper. And so that outlines every single hearing that we're supposed to have in the first 12 months that a child's in foster care. There's really a minimum of 6 hearings, and that's a minimum. Most of us do hearings much more frequently than that. The code requires, for instance, that there be a permanency hearing at least every 6 months after the first permanency hearing. We often will schedule a court review at 3 months so that we're not waiting for 6 months to find out if there's a problem. If we feel like a service is not being provided, we can have a hearing 1 month later to address that concern. So these kids are having regular oversight by the court, by their attorneys, by their CASAs, with the goal of achieving permanency for whatever that permanency outcome is for the child, whether that's reunification, placement with a relative through a direct placement instead of foster care, being adopted, or APLA. So again, the system is designed to support safety, reunification when safe, alternative permanency plans when reunification is not feasible. So our placement options include traditional foster homes, family foster homes, and those are ones where a grandmother might be approved, go through the foster system so that they can receive reimbursement. Relative placements, which are when a relative is able to safely care for the child. They don't need to enter foster care. They don't need to have those dollars, but the department has vetted that relative to assure us that they're a safe person to care for the child. And then group homes when necessary, as well as emergency placement options, which have been talked a lot. Other folks have talked about the wraparound services, the behavior aids, transportation, visitation supervisor. Before November 2025, those were readily accessible. Most often when we got to a non-emergency dependency petition and a child came before the court, and maybe the department was using a safety resource before they filed their petition, we often had assessments for the parents. The parents already knew what they needed to do to either avoid their child coming into foster care or what they needed to do before reunification. We also saw children getting visitation within just a couple of weeks of entering foster care. So they were regularly visiting their family, visiting their siblings if their siblings were placed separately. And we had an ability for SAGs to prove their dependency cases. They were able to present all of the factors which they felt led to this child being abused or neglected, whether that be substance abuse, mental health, not very often lack of education in going to school, but sometimes that was a factor. Dirty houses is a frequent problem. So they were able to bring every single allegation to the table, and they were able to fully investigate and prove that case in court. And we were able to regularly get drug screens. And a lot of our cases are substance abuse. It might come in as a call for educational neglect or dirty house, but what we often learned was that most of our cases had substance abuse as a factor. And so the department was able to provide regular drug screens to both help establish that factor of dependency, as well as to help assure the court that a child was no longer dependent because the parent had addressed their substance abuse dependency and this child was safe to go home or safe to have unsupervised visitation, and things like that. And again, we almost always had assessment results, so we know what the parent needed to do by the time we got to that 30-day dispositional hearing and we were approving a case plan. We also had clinical and educational supports for children and kinship supports that are provided through the department. So after November 2025, there was an additional state level of review and approval. I think our experiences from what we've heard from the juvenile court judges is that varied from county to county. Some had a much faster time of getting service authorizations approved. Some had no problems, some had significant problems. Some services were suspended or eliminated entirely, and then have only recently come back on. New cases were affected most because the service authorizations that were in place in late October, early November remained in place until they expired, but most of those expired at the first of the year or shortly thereafter. We experienced problems with therapy services being abruptly stopped for children. And while we certainly understand the department's position that we should utilize Medicaid when available, and we should utilize Medicaid providers for therapy, it did cause significant service disruptions for children who were kind of, in some cases, abruptly pulled out from their therapeutic provider without having a provider to go to, or they were disrupted in their very important therapeutic work that they were doing, which caused placement disruptions and caused significant trauma in some cases to our children. So while we're certainly mindful of using those resources in a good and thoughtful way and utilizing Medicaid when we can, we certainly hope that in the future, we can avoid service disruptions and have a smoother transition when situations like this arise.
It increases the amount of time before they can get to permanency.
Exactly. We also had our case managers learning through trial and error what was it going to take to get a service authorization approved. And I would say in the beginning, we had case managers working a full week to try, like when you count up the hours of the day over a 3-week period, it might have taken them 36 hours to get a service authorization approved. And a lot of frustration from the case managers. They were also doing most of the transportation for visitation, supervising visitation. And then we had delays in services even after they were approved. A lot of services were not approved. Again, talking to the point of having parents pay for their own treatment or assessments. That's a great idea. And certainly that works when a parent has insurance. But a lot of the denials that some jurisdictions saw involved telling a parent, you've got to apply for Medicaid first. And so here we are 6 months later, multiple kids in foster care, and a parent still doesn't have Medicaid and still hasn't started services. So while, yes, it would be great to have a parent be able to pay for those services when they can, what it ultimately has done was delayed children having permanency and extending the time that they spent in foster care. We also had significant barriers to getting visitation services in place. There were some families who went months without getting their court-ordered supervised visitation. And some of that was because of new requirements to be able to have a service authorization approved. But it also is an impact of a larger problem in the system, which is not having the foster homes, not being able to use the foster homes that we have in county to host the children in foster care in that county. And so you've got significant travel distances. Sometimes siblings are separated. And so you might have to pick up 5 kids from 3 different foster homes to visit with one parent. We also, certainly we don't have the insight except for when DFAC shares those numbers with us, but it feels like there's a significant reduction in cases being investigated, or at least cases being filed. So we looked back at numbers, and multiple jurisdictions have a significant drop in dependency filings. So not only just the number of kids coming into foster care, but those who the department is seeking to have court oversight of either a direct placement or a parent where the children are still in the home. So that, we don't have an insight into that, but it raises questions and it causes concern. If there's been a consistent number of calls to the hotline and reports, why is there such a significant downturn from pretty steady past numbers? So the effects have been that, again, parents weren't necessarily able to obtain services unless they had Medicaid or a provider, or if the department did approve a service authorization, it took some time before that happened. Therapeutic and behavioral supports for children were disrupted. Visitation was reduced, and a lack of or a reduction in early intervention has led to kind of increased needs. For instance, delaying court intervention can lead to a disruption of a safety resource that may have been willing to continue to serve as a direct placement and avoid foster care. Parents who had kind of not significant substance abuse when the case was first reported and started working with the department, the lack of follow through has on occasions led to a more significant level of care like residential treatment or MAT being needed. So the impact on permanency, again, when we get to disposition, we're supposed to approve a case plan. That's one of our required things to do at a disposition hearing, which has to be held no more than 30 days after adjudication. And in those case plans, we have to list what a parent is supposed to do to achieve reunification. And most often, we already knew what they needed to do because we had those assessments. If we don't have those assessments, we're just guessing at what a parent needs to do. And so we need to have those assessments to be able to make recommendations early on the case so that the parent has a realistic chance of achieving permanency or achieving reunification within 9 or 12 months as the code requires. Those delays can extend the time a child spends in foster care. It also prevents parents from getting engaged and addressing those underlying causes of removal. And then oftentimes we, as the courts, are scheduling more frequent hearings, which is also causing an impact on the cost to CASA and to child attorneys and attorney guardian ad litems, because they're in court more often. They're advocating for why their child isn't getting services, or the parent attorneys are advocating for, getting the parent services. And we're just trying to address it as best we can. We have had some no reasonable efforts findings when required services were not provided, which can impact federal reimbursement. So Our suggestions are to target fiscal discipline without across-the-board service reduction, allow the counties and the departments to work smarter with their dollars, allow counties to utilize providers that they have that may be at the fraction of the state contract rate. And I'll use drug screens as an easy example. There's probably other examples, but drug screens with so many accountability courts throughout the state, there are multiple juvenile courts who have accountability courts in their district, and they are willing to provide drug screens to the department at cost. But in the past, and several of those had contracts with the department, but they were paying the state contract rate, which was much higher than what the county would charge. And so I think those providers are still willing to work with the departments, and there may be fiscal reasons for state reasons that I don't know of why state contracts are a great idea. But I do know that you may be paying more for some of those services than what would be available at the state level, at the county level. We want to prioritize services that prevent longer and more expensive stays in care. And one of the questions that was asked earlier was about the number of kids who have those special needs, developmental, neurodevelopmental. Most of our kids receive services, and I don't know whether that's because of in utero drug use or because of neglect for several years, but most of our young kids are Babies Can't Wait.
Yep.
Yeah. Children's First, autism diagnosis, receiving ABA therapy, PT, OT, speech therapy, feeding therapy. And, you know, when we can address those needs early on, we are hopefully I'm not a scientist, but I hope that we are preventing those needs when they are reaching the teen years and things like that. And reducing the cost of high cost congregate and emergency placements. I think y'all have heard a lot about that today, and we don't necessarily have solutions to that other than good preventative work in the younger years on the front end.
Can I add one thing? I know from one of the things that on our presentation before was that one of the driving high costs was those kids with those. Oh, I'm so sorry. Was one of the driving costs was one of the kids that have all of those kind of diagnoses. And so from a judicial perspective, what we tried to do, and I believe Senator Kirkpatrick, you mentioned to Chins, is to involve the department to be able to come to court when we think that one of those issues might pop up, so there can be early intervention. But I almost felt like in the last presentation, perhaps two of those kids that they were speaking of was in my court, because when they do come in on the delinquency side of it, but then they're found incompetent, the way the code is written, I do have to then, if the parent says I cannot safely care for the child and I have other kids, contact DFACS, but I understand the safety issues that it puts them in. So I appreciate you guys being proactive, because I kind of feel like all of these issues are touching upon the very same kind of root of the problem.
And I appreciate you mentioning CHINS. We do often involve our DFACS offices in our CHINS panel so that they can try to provide some preventative resources before we even got to a situation where anyone might be asking for a dependency finding or placement in foster care. Another cost driver is just placement in foster care. And so we sometimes have families who are able to care for children. And so a lot of times the department is asking for direct placement. And so they might still provide services for the family, provide oversight, but someone else is paying to care for that child. And that's great. We have had a lot of families who have needed foster care simply because the cost of putting 3 kids in daycare is undoable for a grandparent or an aunt who's got her own kids. And so if there's a way to look at being able to provide Medicaid and caps for families who financially don't need that roughly $400 to $500 ERR reimbursement and wouldn't have to go through the foster care training to do that, that might help get more direct placements with family rather than having to place that child in foster care, but then placed with a relative. Again, maximize federal reimbursement. That's been talked about a lot. You know, there's very few requirements on our end, and we usually rely on our SAGs to make sure they're putting that special language. And even if it's a situation where the parent says, I can't do it, and the department was not necessarily expecting to take that child into custody, we'll confirm with the SAG, does this have all the magic language you need for federal reimbursement? And so other than the no reasonable efforts findings, we're doing everything we can in our orders to make sure that a child is eligible for reimbursement if all the other factors were met. And in the rare circumstances where we found no reasonable efforts, we're also offering an opportunity. I'll purge this finding if you come back in 28 days, a month, fixing these 3 problems. And then it's just a short little gap that they're not covered. And then another suggestion is to evaluate the barriers for children reaching permanency. Once a child has been in care for 15 to 22 months, the department shall file a petition for TPR unless there are exceptions. Those exceptions can include that that's not the best plan for the child, maybe a permanent guardian. It can also be that the parent is making progress, but they still need more time before reunification can be achieved. But there appears to be a lot of low-hanging fruit that if we did some targeted work on, and I'll say this is not a problem in every jurisdiction, but in some jurisdictions, there are lots of documented cases where the department has announced TPR and it still takes more than 15 months before a petition is filed. A lot of that appears from their viewing of the cases to be mostly based on case management turnover, lots of paperwork being needed, not having the correct paperwork. So just working smarter for those kids who can't go home. Some of those cases, parents had passed away. And so it's really just getting that. They're in an adoptive home. They just need the paperwork to be done, the petition to be filed so that they can reach permanency. So just kind of maybe a study committee to address that. I think the judges are having frequent hearings, the child attorneys are advocating, but you know, unless someone else can file the petition, and a lot of times because of legal conflicts, they can't, the department has to file that petition. So our suggestions are to restore and protect core services. I will say that things seem to have loosened recently. We're seeing quicker times to achieve supervised visitation, but prioritize safety, reunification, permanency, and placement stability, protect assessments, visitation, and treatment for parents, invest in early intervention so that these kids don't have to come into foster care, and reduce administrative duplication. So we frequently would see 4 different assessments. So what's federally mandated when a child is in foster care is the CCFA. The other assessments are usually substance abuse, parental fitness, sometimes domestic violence. So you're reading 4 different assessments that all have copy and paste 20 pages of the same language. You know, 3 pages are the good stuff, the testing instruments, the specific assessments that get to the heart of the matter. And so being able to kind of bundle those services without having to pay for multiple assessments, if that's possible. And then increase the number of foster homes. That's been a longstanding problem that we have all tried to address within our own circuits, with advocacy, with partnerships, with speaking to churches, speaking to groups, to try to get more foster homes. But if we had more foster homes, especially local, that would help resolve a lot of the problems regarding transportation. So 2 would be, this kind of talks to the cost drivers, and I'm really talking about everyone under those top 18 that was referenced before. But for legally required evidence-based core services, be able to automatically approve those. Expedited reviews for moderate cost services, and then reserve the state level approval that takes several layers to get through for those high cost, long duration, or non-standard services. and set some approval time limits. I don't know that this is still the issue, but at least in the beginning and even as recently as the first of the year, it was taking significant time to get service authorizations approved. So, and again, that may be different from county to county, but this is what we were told folks were experiencing. So, decrease the time it takes to get those service authorizations approved and allow for them to be approved for as long as they would need to be provided instead of having to come back for a new approval every 30 days. For instance, if it takes hours to get all the documentation needed for mom to be able to visit the child 3 counties away, don't require that case manager to reapply every 30 days. Do a longer benchmark. And then use local resources when they can provide quality services at a lower cost. Okay, I talked about most of that. Okay, so I'm going to skip the part about the reliance on those high cost providers because I think we've already talked about that. I think the only other suggestion that I might have is to kind of create a task force that will deal with those most special needs. I think that is one of the biggest drivers to brand new case manager burnout and turnover is dealing with these kids. The foster homes are frustrated and running out of options. But when you have a new and inexperienced case manager who doesn't know that they need to make sure that medication leaves the 1013 with the child before they go to a placement, if you had kind of experts in that area who can have those good working relationships with the other agencies who are helping provide the care, that might be a good way to try to have some specialization. We've had some real great success with our specialized adoptions unit, who is able, knows everything they need to do, knows the resources. So if you had maybe a specialized unit who could deal with some of these higher needs kids, they might become specialists and be able to work through some of the problems better.
And I don't think obviously, I'm glad the task force is here so that, I'm sorry, I keep doing that. We're not necessarily saying that has to be through the Department of Family and Children's Services. These are just things that we were coming up that may help with some of that cost. And I'm not saying create a whole separate agency, but I'm just trying to say we're not trying to add more to that plate.
Yeah. Expanding kinship care. I've talked a lot about this already. I think the one other thing that we have experienced is that even county to county, but even case to case, we don't see consistency in what the department's rules are on placing a child with a relative. So sometimes the child will be in foster care for 2 or 3 months until they've gone through the full assessment. But in other times, they're talking to a grandmother at removal. And as long as we've got a drug screen and a background check, they're able to safely place with a relative while the relative goes through the process to be an approved foster home. So some looking at that, looking about whether can we place the child with a relative while they're undergoing that full assessment, as long as there's a walkthrough of the home and you're relieving those immediate safety concerns. Accelerate safe permanency. Every month a child is in foster care carries not only fiscal costs, which is kind of the topic of the day here, but also emotional costs for these children. And really, some kids can't be returned to a home safely, but for those who can, every minute that they're without their family and without their siblings is impactful. So really just keeping that as the focus. And then track barriers such as delayed hearings, incomplete case plans, delays in providing services. So we can really drill down to where can we all improve on this? And I know J4C and Court Improvement Project has done a lot, and they're doing some targeted work on I think 5 different counties to figure out why are cases being continued, things like that. But we all need to be looking at how can we make sure that we're not extending a time that a child spends in foster care. And then measure permanency by the child outcomes, not simply case closures, and then address the delays in filing TPRs. Again, I don't think that's a problem everywhere, but for the counties that are experiencing that as a problem, I think you could save significant dollars that way. Federal reimbursement has already been talked about a lot. I think I'm going to kind of skip over that, except for Georgia has worked hard to expand the number of counties that are doing the QLR program. That's the Quality Legal Representation Program. And so many counties are getting federal reimbursement for the child and parent attorneys costs, which is saving significant county dollars, but it's also creating higher representation, which is hopefully getting those children to permanency faster. And all of that reimbursement is tied to that penetration rate, which is at 37%. Oh, sorry. Okay. So strengthen transparency and accountability. Again, this is the great work that you guys are doing to solve all these problems. But, you know, if we could target why kids are staying in foster care longer, I think that will help everybody, DFACS, child attorneys, judges, figure out what they need to do to work towards fixing that. And really maintaining state quality standards for treatment for children and for parents, but also giving local leaders the flexibility to use services within the community that are available at hopefully an often lower cost to the state. Prevention and quality investigations. Again, investing in those family prevention services, using that federal reimbursement for that, tie prevention to measurable reductions in removals and repeat maltreatment. I think the more often you're removing a child, the more significant expenses you're going to have later on when that child's a teenager. Another problem that we have heard about frequently is from our adoptive parents. I think my hardest cases have been the ones where an adoptive resource or a permanent guardian brings the child back at age 15. And those kids by that time have significant needs, but I think from hearing from foster parents, there's a lack of preventative services when they start to struggle with those children to be able to prevent that return to care. But those are the kids, they're the higher cost dollars that are going to group homes instead of foster homes. So looking to see whether there's extended resources that can be made available to adoptive families or permanent guardians to reduce those teens from coming back into care. And then again, ensuring timely drug screens and assessments during both investigations and family preservation will hope either get cases to court faster so that there can be judicial oversight over the parent or helping prove that the child is no longer dependent and can return home.
And to piggyback on that, one of the things that I know Judge Toller keeps mentioning, we're trying to encompass 159 counties, but the way that this is happening can vary very, very much depending on what county you are. And lots of times it depends on where the location of your resources are. So I may talk to one of my fellow judges that are in the metro Atlanta area, and they have certain services that I don't have in my area that then sometimes affects the prolongedness of when that child's going to reach that permanency. And that has been, especially when they're in that higher cost realm. Well, how far are the services that this child in my area requires? And that's a big driving force, at least from being middle Georgia, that I kind of see that we don't have access to as readily as some of those in other areas.
Workforce stability. I know that the legislator has been looking at this for a long time, and there have been pay increases and things like that to try to retain workers. And I know their pay has gotten better, but it's still a very difficult job. And, you know, some caseworkers have said, I can go work at Target for more and I don't have to be on call and I don't have to do this really hard work and take all this trauma home with me all the time. But families are experiencing sometimes 5 to 10 case managers in the limited time that they're working with them. And there may be a way to avoid duplication of resources. So when a child moves from foster care back home, and with oversight by the department, they change case managers. Sometimes 2 kids can go home before the 3rd can, and then you've got 2 different case managers. Sometimes you've got 3 different case managers for whatever reason, but being able to cross-train your workforce so that they can have stability and provide everything that that child needs without having to switch over, maybe a way that we can avoid that. Another issue, and I think with the counties who did the deep dive into why TPRs aren't being filed, when the department announced that they would, some of that was the case manager not being familiar enough to be able to fill out the packet. So having that oversight by a supervisor who can provide that smooth transition, or not having the issue of constant turnover, can help get these children to permanency faster. And I will say that really educating the workforce about all matters of what the department does can be really helpful. We had a significant reduction in the time it took, and I'm just speaking locally to Hall County, when our foster care case managers were trained on what is needed to get a child to adoption. And they started doing that while they were getting ready to file the TPR. The number of months that a child spent in foster care after TPR reduced significantly. And our goal is to be ready to have that child adopted by that first adoption efforts review hearing 6 months later, because the department had the birth records, the birth certificates, everything they needed when they filed TPR. And at TPR, they were able to testify about all those efforts that they made. And that was just locally in Hall County, a targeted effort by the department to train those foster care workers on what they needed to do, and it had great impacts. Okay, so I think that's about it. I've talked a lot, and I'm happy to answer any questions you have, but we've also got Judge Dunn taking notes, so if there's anything else we need to follow up on and send to you after the fact, we're happy to do that.
You are going to have some questions and I'll start, but thank you so much. You clearly have given this a lot of thought. You didn't throw this together in 24 hours. So much appreciated, and we'll study up on everything you brought to us. That's a lot of information. We have 159 counties, and what we learned in the process of the data gathering project that we started with Senate Bill 401 is that we can't operate on data that we don't have. So the Supreme Court effort, the J4C effort, is also much appreciated, and we work with them closely, and I'm sure we'll be hearing from them at another meeting. I'm going to see who has questions. A lot of lights went off at the same time. Representative Gullett.
Thank you. Thank you for what you do. As judges and both for the children, I heard a lot today of things that you guys see and believe could help the process from other agencies, what you want DFACs to do, what you want caseworkers to do, what you want DBHDD to do. What can you guys do? This is a joint committee on evaluating escalating costs in Georgia's foster care system. You're part of that. It's not just DFACs. What can you do? And I will say, I will love to see the counties that have permanency hearings more than every 6 months. That, I don't believe that exists. I know there may be a few. That is very, very rare. I find that most juvenile court judges are having a hard time meeting the court calendars for the items that are mandated by law to make. And oftentimes when they do it, it's like a doctor. You feel like you just there talking to them not long ago, but they read your file right before they went into the room, and they haven't really processed everything that's been going on with you. And that's kind of what I see with some juvenile court judges and situations. But what can you as a judge do? What is your advice there? I didn't hear much of that. I heard other places that you deal with.
Sure. So, okay. Okay, so a few different things. First is collaboration, and we frequently work with our stakeholders to collaborate. We, used to have MD Candy trainings all throughout the state, and those were a great opportunity for DFACS frontline workers, supervisors, directors, lawyers, judges, CASAs, all to be at the table to really examining where can we work in our circuit, in our county, to be better and to achieve reunification faster. And those were put on throughout the state. I think every single circuit had the opportunity to have that training. And once we finished MD Canny 1 and 2, we moved on to 3. And so it's kind of a continuing education. A lot of us meet frequently with our DFACS directors. And I think generally the judges have really good relationships with their local DFACS office, and they talk through problems. I mean, in our circuit, we generally had like a quarterly meeting with them to just kind of problem solve, talk about, what do you need from us? What do we need from you? Having those discussions. And then things like the summit, just partnering with child welfare agencies and partners to continue to try to be better. The more frequent hearings we can continue to do. I know that you talked about the data. And so now I don't want to misstate this, but I think most, if not all, our counties are now able to upload that data to the AOC, and that holds us accountable. And if there are certain counties where they're not having regular hearings, we can help try to identify why and work on that. But I know that the judges that I've talked to, we are working hard to make sure that we have a hearing as statutorily required, if not more. And I do believe there are a lot of judges who are having more than the statutory required hearings.
It's a balancing act, and we're talking about when we're on the bench, but I know for us, one of the things in our community, so is bringing all of them to the table, was a lack of appropriate legal representations because they don't make a whole lot of money in this. So some of the advocacy of making sure they were coming to the court when these issues arose required me to then advocate to my local county and then look at it on a state level to see how we could increase the pay to get better legal representation. And then it was also getting feedback from our SAG and our DFACS about what we could do to help them out. And at least my local Houston County, and I absolutely appreciate my DFACS, but they are the ones who enlightened me on a lot of our work is family preservation before they even get to the dependency. So the earlier we can get involved in the case and put services in place, it might prevent us from having to get them on the dependency side. So then I started sharing my calendar when there was a CHINS issue, or even sometimes on the delinquency when there would be a crossover that we thought that they were repeatedly coming and the parent was at the point where they couldn't properly care or provide for the child. I brought DFACS in place to at least know what the issues were so they could start working on those services. So we're speeding up that process as much as possible. So to answer your question, it'd be collaboration, which is what she said, working with, and it comes back to me to Senator Albers when you were saying, is there a model situation? And they were saying Georgia's going to have to look at their stuff. That's what we have to even do locally. What are our needs and how can we address that?
And we do try to collaborate. So I know that one of the frustrations has been, or kind of one of the things that's been talked about, is custody from the bench. We don't remove a child who's delinquent to foster care unless that parent has said, I'm just not getting him, and walks out the door. And then sometimes we'll wait it out till 5 o'clock and see if anyone's coming to pick up the child. But we locally also have, and again, this is just Hall County, but we developed a multidisciplinary review team so that before anyone is going to be asking for removal to foster care, it's going to be staffed, it's going to be reviewed. We're going to see what other, not the judge is not involved in that, but the partners are, and that's DJJ, DFACS, probation, sometimes a guardian ad litem, to ask all the questions, provide all of the necessary vetting, look for other resources, ask all the questions before you're even allowed to make that request. So we do try to partner, and I think the judges across the state are willing to do more partnership with their local, not just the Department of Family and Children's Services, but all agencies who work with child welfare.
And I'll give you an example. I had a parent recently that had adopted, and the child's a teen and has a lot of behavioral issues. And my department head came to me and was like, I just really think this parent doesn't want to parent because we've tried to put services in place to help them deal with these behaviors and they won't be a part of that. Can we prosecute them? I work closely with our magistrate and I said, but it's a misdemeanor, but you can definitely make that report and see if you're going to hold them accountable. So it's keeping that line of communication on how we can tackle the issues with this particular family.
Okay, thank you.
Judge Will, y'all yesterday, and I'm glad there were not further injuries, and I'm very grateful for all the training that went into the.
I appreciate that. Thank you. I was just telling them that 2 days ago, because we had a lot of our superintendent and stuff like that has just retired. So we have new people on board. And when I talk about collaboration, I want to make sure we were all on the same page. So literally 2 days ago, we were, maybe it's not joking, but we were talking about how they might have to bring metal detectors into school. And I said, oh, are we at that point? And then yesterday to see all the police officers racing to our high school because there was a shooting, I said, gosh, we might actually be at that point. So
Thank
definitely.
you for all you do.
Thank you.
We've heard a lot about court orders in the last several budget cycles. Has there been any attempt by DFACS or y'all to meet together and kind of sit down and go over these orders? I think there's some fair legal issues there that I don't have answers for, of course, but there's legitimate questions. Have y'all not kind of addressed this together in the same room?
I think that kind of the anecdotal response that I could give is that a lot of the judges are talking to a lot of the SAGs, and I think they're in good communication, and I think they have good partnerships throughout. And so I think those conversations are being had, and when we have questions about where is an outstanding order, we'll reach out to the SAG directly. I don't think there's been a Council of Juvenile Court Judges meeting with the head of DFACS or the Attorney General, but there is a lot of collaboration from county to county with the SAGs and the judges.
Your details are helpful about solutions, and I just wonder how much of that has been fleshed out. Very briefly, do you think all of the judges have the benefit of having the IEPs in front of them when they're making decisions? Because we at various times have said the judges should always have an IEP as part of their analysis.
It's sometimes tendered as an exhibit, but where I usually get the most information about IEPs, 504s, and where a child is on, sometimes I'll have the EPAC kind of assessment testing for children. It's all depending on whether the SAG gets it from the case manager and whether they tender it. But the CASA reports and the department's case manager's testimony almost always addresses whether there have been IEP meetings, whether the parents are going to those IEP meetings or 504 meetings, and so I do feel like that's something, at least, and this is not a question I vetted to all of the judges, but at least in my experience, I feel like the case managers know to ask those questions. The foster parents are involved in that process, and the CASAs are very involved in gathering that data.
Obviously, there's cost sharing, that's the cost obligations around the table, and that's what I was asking. Thank you.
Thank you for being here. There has been prior testimony by DFACS that up to about 10% of the foster kids have been custody by bench. I've not heard that term before, but I think that's the correct term. Are you seeing either anecdotally or through the council that DFACS is objecting or appealing your orders? And if so, what's the rate of being overturned or I mean, are you seeing any of it? I had asked for it, and I got, notwithstanding, I was told that 10% are being appealed or hundreds are being appealed. I got like 7 or 8 throughout the state. So I don't know what you're seeing on the ground.
Well, we have 2 trainings each year, and we go over any cases that have come down from the Court of Appeals. And so I haven't seen many cases that's come down from the Court of Appeals addressing that particular issue. I don't know if it's as common as, and like I said, obviously that's why we were like, there's a wide representation here, but for Houston County, I can tell you that I haven't had anyone complain or raise it because they're involved so early on, and there is such a communication with my SAG. The rare occasion, there has been a couple occasions where my DA has indicated that they thought there might be a dependency issue from something they've investigated, and then I set it for a hearing and they come to my dependency hearing, and then the attorneys present the evidence and I make a ruling based on the evidence that is presented to me at the time. So I think depending on how detailed our orders are, there's just hasn't, at least in my county, hasn't risen to the point where they felt they had anything to be able to appeal upon because all the parties are represented and able to present their evidence. And as long as that's detailed in my findings of facts in my order, then they're,
Thank you.
I'm not aware of a large number of appeals. And I will say that, and this kind of addresses, again, the Chin's question, but there are a lot of cases that do end up in dependency filings and sometimes removal that come from Chins and from other, from maybe an underlying delinquency that might have existed. But those are usually cases where there's been a significant investigation, perhaps a guardian ad litem is appointed because there's a reason why the child is truant. And there's, there might have been multiple referrals from educators with that family. And so there's usually a lot more history than, and I think it's very rare that a judge is giving, is placing a child in custody without there being at least some forewarning or request to investigate and things like that. So, we're not just sua sponte doing it. There's usually a guardian ad litem that's been appointed. They've investigated, they're making the request, or multiple services have been put in place to try to prevent that before it's happened.
And one thing I would say I've noticed, I got sworn in 2021, and there was the enactment of kind of combining some of the dependency and the delinquency and everything on the JCAT system, at least where we are in Houston County. So that has been a very useful tool for me because then I have the whole history. So when I'm doing my findings of facts, not only having the ADA, the DFACS, and the school board, sometimes Mr. Jurls representing the Houston County School Board, I also have that paperwork and data about everything that has been trying to do before we go to the point where we feel like they need to be placed in the foster care. Because as we've indicated, and I go back to our original representation, what do we want for this child? And what I want from a judicial perspective is that we've exhausted everything we possibly can do before we have to put them in care.
Thank you. Good to see you.
Thank you.
And Judge Dunn, thank you all for being here. And you as well. I just happen to live in that area. We're glad you're here too. So couple of questions, and maybe we simplify this down specifically. I'm going to use Hall County as an example. Currently, how many children have been placed from Hall County?
Like this year?
Or just like right now, where are we sitting?
I will say that traditionally, we have averaged about 250 kids in foster care going back the 12 years that I've been doing this. And typically, we had about 100, sometimes 120 dependency petitions filed every year. And so not all of those were an emergency removal order. Some of those were the department filing a petition and then again, requesting that there be court oversight while the child remained with a parent or placing with a relative, or when we got to adjudication, the department asking for foster care. And I will say that with the exception of this week, which has been unusual, we have had some months where we have not had a single petition filed. But by and large, we're only seeing 1, 2, maybe 3, where it was usually 10 to 12 per month. And so, and I am not, Hall County is not unique. A lot of judges have expressed concern about just a very big drop in the number of petitions filed, either emergency or non-emergency. That doesn't mean it's happening everywhere, but it's been a topic of conversation at the last 2 statewide judges meetings.
Okay. Well. So I had met with CASA in Forsyth 2 weeks ago, and we had a conversation as it related to, there were roughly 100 kids in DFACS in Forsyth County. And our battle, and Judge Dunn, you can maybe help confirm some of this at a later date, but was quantity of foster care homes. And specifically in Forsyth, I believe that number was around currently around 7. Does that sound right? Right. Okay. So I think my question on a larger scale, chairs, is we have one sheet I'll see, it says 9,000 across the state, and we may have 10,000. We may have less than we need to have for budget reasons and things we're trying to figure out. I care about how many kids are out there. The other thing I care about is how do we increase foster parents within our communities? And I think sometimes we look at it as statewide, and y'all have, how many districts are there for the judges? 50, is it 51? How many do y'all
Remember?
Is it 50? Something like that, right? And there's 14 regions for DFACs, right? Which do not align with our congressional districts either. So y'all are juggling multiple regions, which makes this thing very complicated. To me, it makes it complicated. It may be, y'all may be smooth sailing, but I would just like to, and I think Representative Gullett had a great question, was what can y'all do, or what is your greatest struggle, and how do we help solve that? Looking at, we need more foster homes.
As it relates to foster homes, I think that we always give foster homes or foster parents the opportunity to speak after the presentation of the evidence, before the attorneys give their closing arguments. Zoom has been really helpful, at least for us, to allow more foster parents to come without having to take the whole day off of work. They have expressed frustrations with, being asked to transport kids for visitation and things like that. So taking care of them, I think, is important. And the part of the problem appears to be kind of the supply and demand that Casey Family Programs talked about. But DFACS is trying to find the first available home that will be available for the child. So my child that I just removed might be taking one of your Forsyth County foster beds. And that's not a horrible thing, because it's maybe 45 minutes max in transporting a child back and forth. But
it could be in Raven County.
It could be.
So now all of a sudden we're all the way up there, and it's
Right.
not close, where you could have just been in North Fulton.
Exactly. Or we've got 2 kids in Bibb County and 1 kid in Snellville and 1 kid somewhere else. And so then you've got providers making a circuit. And for these kids, it's a huge, long day to achieve visitation with the family and with their siblings. So I don't have an exact solution for the mechanism to fixing that problem. At one point a long time ago, there was a targeted effort, like, let's try to find 5 kids who can be resourced back to Hall County. And I don't remember if that was a statewide effort or if that was just a local effort, but once they got one of their children placed back in Hall County, they were able to move on to the next down the list. And so they had that targeted effort. I will say the placing agencies are wonderful. And so if we can get the placing agency to look for, 2 siblings are here and the other one is 2 hours away. We recently had a situation where the placing agency was able to locate or target another family that was close by within the same agency. So at least the brother could be placed near his siblings and the dad could come down and visit. And that reduced a lot of the extra costs that were associated with it, and gave the ability for the siblings to get together more frequently through the foster parents.
Okay, thank you.
Chairman Kemp.
Right. Thank you so much for being here, both of you. And my heart does go out to Houston County.
Thank you.
Thank you. Yes, I grew up in Dublin, so that's very close to home.
Very close.
Very close. But thank you for being here. I had a question, and this kind of goes back to the whole nature of how you determine what your order is. So this information comes from your SAG recommendations, correct? All right. So, and then you do an order. Has there been a time in either of your courts, I know you can't speak to every juvenile court judge in the state, where perhaps a SAG has brought something, or maybe you have added something to an order that DFACS has opposed, or they have asked for a lower cost alternative that you can remember? Again, this is not everyone in the state, because there are 2 of you here and you're only responsible for your courtrooms, but I'm just curious.
So I think that it kind of works in a multitude of different ways. There have been some times where DFACs put in a case plan for both parents to have a psychological because that was what was recommended in the assessments. But the parent attorney might have objected and said, there's no mental health concerns. This is a straight substance abuse case. We don't feel like a psychological is necessary. And we might make that decision, let's hold off on those dollars. And then if it appears that mental health is a concern, then we can do a psychological at a later time. There may be cases where a judge is ordering a service. I think what I've experienced most frequently, if the department has pushed back on it, was related to communication, like to have a family team meeting to follow up on whether these services are being achieved. Sometimes I have done that in cases with those high needs, high dollar kids where there were things falling through the cracks like medication and therapeutic services, and not everyone was talking to each other. So I might order the department to facilitate a conversation to make sure the child was getting their services. And so I don't think that's necessarily a service I was ordering. It was an act of the department to ensure that things were being followed up on and the child was receiving all the necessary services.
Was there any objection to that?
Sometimes.
Okay. Okay,
And
thank you.
I haven't.
Senator Wicks?
Thank you.
Thank you for your presentation. I just have one question. Which state agency is ultimately responsible for placing our children when they cannot be placed in appropriate setting?
The way the law has been, DFACS decides about placement unless there's a safety issue. So that is a department decision. And to go back to your question, the rare occasion I've had is, and it's been very, very rare, but sometimes they'll give me facts and my logic brain would be like, well, that doesn't make sense. Why this? And sometimes they'll say, well, the policy says, but if based on what we've testified, Your Honor, you feel that this would be more appropriate, then I cannot say that I won't do what you're saying based on the facts. But that has happened very rarely, but I have had some times where I'm like, okay, so my inner voice is telling me with this particular case, the policy is not matching that has happened, but it has been rare, but that has happened sometimes. And sometimes the policy won't match what the law is today. So then I'll have to go based on what's presented to me and do what I think is appropriate for that child.
Thank you. To your question, we have no control over where the department places the child. So we can say if we think a placement is unsuitable for a child, and that happens very rarely, but we can't even say you need to place with grandma. Nope. The only way we could do that is if we were to make a decision to make a direct placement with the grandmother and she would receive no resources from the department. So DFACS is solely in charge of making those placement decisions.
And I've had where there's families competing about who they feel is the better placement. And I always say that's the departments. And sometimes they'll say, well, the child has already been with this placement. We think it'll be too disruptive to move them to this placement, especially since it seems like reunification is going to take place. So there has been that discussion, but it's ultimately with the department.
Thank you so much. Thank you for your presentation. I appreciate your colleagues tagging along. We appreciate you being here.
No, thank you very much. I feel like this is a very proactive way to try to figure out the solution. So I appreciate you guys taking the time and giving us an opportunity to be heard.
And if there's any questions you have, any specifics you need, we're happy to follow up and gather them.
Don't worry.
Thank you.
Yeah, committee members, we are behind schedule. And so if anyone gets hypoglycemic, there's lunch for the committee members in 318, but we're going to forge ahead because we'll have a full agenda for the next meeting as well. And so I do want to hear from the two agencies that are still on our agenda. And we'll start with DBHDD if you want to come down. Dr. Doyle. And committee members that have to leave, you just a reminder, you'll be able to watch the live stream later.
Can I use the arrows to advance? Technology.
Thank you for being here. Maybe you can catch us up, but I doubt it.
Well, I will try and be as quick as I can while still being coherent.
Speak loudly because we do have people on Zoom.
Yes, ma'am. All righty. Good afternoon, Chair Camp, Senator Kilpatrick. Thank you so much for the opportunity to be here, and to the rest of the committee. My name is Dr. Christy Doyle. I am the Senior Director for the Office of Children, Young Adults, and Families with DBHDD. I have been in that capacity for about 1.5 years, but have been in state service for approximately 30 years now, and have spent the majority of that time in child serving capacities. So I would also like to thank Commissioner Tanner for allowing me to be here also. I would like to provide just a brief amount of context on DBHDD. You know, we, of course, are the State Behavioral Health Authority, a $2 billion state agency, and we are responsible as the safety net provider for providing mental health care, substance use treatment, and support for developmental disabilities, as well as a chunk of the crisis response continuum. In response to some earlier testimony, I would like to talk just very briefly and clarify that the federal regulations around early periodic screening, diagnosis, and treatment, EPSDT, you have probably heard it called. Through those regulations at the federal level, DBHDD is not allowed to serve individuals who are under the age of 21 because that is part of our state's state plan benefit. Those children would need to go on the planning list so that DBHDD is prepared to transition them to appropriate services when they do turn 21. But in the interim, we work very closely with our colleagues at DCH, who does administer our state plan, and they are an active member of Match and just very engaged to collaborate and help determine what services are available and can be provided. So I did want to mention that. So DBHDD's target population is something I would like to touch on briefly before we get specifically to Match, which is where I would like to spend the majority of my time. I did want to clarify where DBHDD does fit into the larger child serving system for all children, including those in foster care. It's a distinction that's important for today's conversation, I believe, because no one agency, as we've heard over and over, can answer all of the need for Georgia's children. It must be a system-wide collaborative effort. So again, for children in foster care, we are responsible for providing the safety net behavioral health services, while DCH and the care management organizations do have a large portion of the behavioral health Medicaid and covered benefits for these children. So one of the primary points in which DBHDD does help serve this population is through Match. And our role with Match is to work closely with all of our state partners, including our partners at DHS and DFACS. You heard from Audrey earlier, who does sit on the Match committee. So again, we all work very closely together to help address the needs of children with complex cases and try to identify the available and appropriate services for the children. So the goal of Match, and as it has been operationalized, it does allow the agencies and DBH to work across what the traditional boundaries, or we all talk about them, right, silos, what those may have been, to try to come together and identify the most appropriate plan of action that could not be effected by a single agency working alone. And I was remiss, and I apologize. With me today is my colleague Heather Stanley, who is the Match Director for DBHDD. All right. One of the other things that you will hear us talk about today are our Match pilot programs, and these are clinical services that are funded through social services block grant dollars that are provided through our colleagues at DHS. And we'll get more into that with regards to specific clinical services. So What is match? We have had this conversation before, but I would like to hit it as a refresher. It's a statewide coordination process for our state's highest needs children. These are the kids with complex behavioral health needs in situations where local resources have not been sufficient. Many of these children are multi-system involved, behavioral health, DFACS, DJJ, etc. Match was established in HB 1013 in 2022 and was housed within DBHDD. And again, the role of Match is to try and remove those barriers and come together to develop those plans. So there are a couple of key core functions in Match. One is the State Match Committee, and the other is the Match Clinical Team. The Match Clinical Team is operated by Ms. Stanley and her colleague Danielle Fish, and is comprised of the relevant state agencies, so DBHDD, DCH, DOE, et cetera, as well as Kate's specific partners. So the local interagency planning team representatives may participate, local treatment providers. If a child is covered by Medicaid and are a CMO Medicaid child, the Medicaid Behavioral Health Care Coordinator will participate to help determine what is covered under that child's plan. The goal of the Match Clinical Team is to review all referrals that come to Match. And I'd like to say that there is no wrong door for Match. Anyone may make a referral. A parent, an agency, a treatment partner, a school, anyone may make a referral to Match. And they begin with the Match team, the DBHDD Match team led by Ms. Stanley, reviewing the documents to help determine what's going to be most effective for that child. Not every child is going to require a full clinical team review. It may be that the Match team identifies the child as appropriate and meeting clinical standards to be admitted to a Match pilot treatment program. And then the partner entities are informed of that, and the child is planned for admission to that program. They might develop comprehensive recommendations for services after convening different conversations that still don't meet that threshold. If the Match team cannot operationalize a solution, they will then convene a full Match clinical team meeting with all of the partners just identified, with the goal of identifying all the barriers to timely and appropriate services and helping to ensure that appropriate services are identified. So the core operating principles of Match are that they are family-centered. I want to say that again, family-centered and youth-guided. I want to emphasize family because children do not exist in a vacuum. Children exist in the context of their family. And particularly for children with serious behavioral health diagnoses, sometimes those families need help. Sometimes those families need training, resources, supports, etc., to help them meet the needs of their child. So any decision that is made specific to a child alone without considering supports to the family, we have heard over and over, is likely to be a less effective solution. And parents and caregivers are invited and actively encouraged to participate in the Match staffing process, again, because their voice and their knowledge of their child is critically important. We do try and make sure that we are trauma responsive. We are culturally responsive. We do refer to and pilot evidence-based practices that have been demonstrated to be effective at meeting the needs of the children that we staff. And we do strive for data-driven learning that we'll talk about a little bit more when we talk about the second key component of Match. So I think the easiest way to say it is our Match vision is that we're going to make sure, or do our darndest to make sure, that Georgia's children and youth with complex behavioral needs receive the right service at the right time, in the right place, with the right supports. So Key outcomes that we are seeking for and key system improvements include expanding in-state and step-down options for children, helping make sure that Georgia's children can receive the necessary care that they need in the state of Georgia, that they do not have to leave the boundaries of the state in order to have their needs met. Again, we've already talked about stronger family engagement and strengthening continuity of care. Fewer emergency escalations. And we have heard several of our colleagues talk about, and you will hear me talk about, the importance of early identification, early intervention. Prevention and early intervention services are our best friend in this context, particularly as we examine the rising costs. I believe that the point has already been well made that deeper end services do tend to be more expensive services. And the more we can identify children and families on the shallower end of the service continuum and meet their needs and be preventative of penetrating more deeply into not just the behavioral health system, but the child welfare and, unfortunately, sometimes the criminal justice system, the more cost-effective we will ultimately be, as well as achieving better outcomes for our children. So that is something that Match focuses on as much as possible. We've also heard autism spectrum disorder mentioned, and there are a substantial number of children with co-occurring behavioral health and autism spectrum disorders who are referred to Match. That is, I believe, 60%? Yeah, roughly 60% of kids referred to Match are co-occurring with autism spectrum. So that has been a focus of both Match and DBHDD internally, is identifying resources for providers to enhance their skills in providing behavioral health services to children with autism spectrum disorder. And of course, identifying services that may be needed but are not available. We'll talk a little bit more about that in Match Part 2. So how does it flow? We talked some about referral and preparation. The referral, the Match team obtains consent, right? Because Match is not an involuntary process, so obtains consent from the parent to receive the records, gathers and reviews the identified clinical information, payer, et cetera, and then convenes the necessary parties to staff the child and identify the least restrictive options for that child. Finally, the team develops a coordinated plan of care and service recommendations for the child and develops timeline recommendations for the operationalization of that plan. And then we have been able to work with many partners to establish follow-up processes to help determine the efficacy of those plans and whether or not plans do need refinement. So one of the big roles of Match is to identify the gaps. Here we've been talking mostly about child level interventions, which is important. We've got to address the need of every child we can. But we have to use the information that we gather from working with those children to develop data that tell us the through narratives of what's missing. Why do these kids keep coming to Match and popping up as high needs? So some of the gaps that we've identified are families who are stuck in emergency departments of hospitals without navigation support. I mentioned we would talk more about Match pilots. Here are some of the solutions that we've developed to this. A partnership with Children's Healthcare of Atlanta and Viewpoint Health to embed care coordinators and navigators in the emergency department there at CHOA to help parents and the emergency room navigate where that child needs to go. Again, not having to come up to Match to do it, but in the moment while that child and that family are sitting in the ED, helping them figure out where to go and how to get there, basically, and supporting that family and navigating what can be a complicated system. Lack of respite options for youth in crisis. We have heard other colleagues testify to the fact that sometimes families feel that they do not have resources and feel that they have no choice other than to surrender their children to the system. Sometimes all they need is a break. Sometimes they need an opportunity for a breather, for their child to receive a crisis intervention, for them to receive some support. And that respite service was something that we heard the need for over and over again. So we have partnered with the Murphy Harps Treatment Center Continuum to provide some of that respite care for these families to help ensure that the family unification can remain stable and that parents get what they need as well as the children. Lack of transitional care for young adults and for individuals with autism spectrum disorders and co-occurring behavioral health disorders. This has been a tremendous gap for those young people that my colleague earlier from DFACS had mentioned, these transition age young people who are moving between systems due to age. And it is particularly challenging for young people with autism spectrum disorder. In response to this, we have stood up a program with the Devereaux Treatment Center specifically for these young men with these co-occurring disorders, which has been a tremendous success. The young men there almost universally have improved and done well in that placement. Youth awaiting residential placement without safe alternatives. Again, sometimes the child is at risk due to self-injurious behavior or suicidal ideations. They need immediate treatment and safety, and they are accepted for a bed, but that bed will not be open for them for another 24 hours. In order to help ensure youth safety and treatment beginning as soon as possible in that circumstance, we've partnered with the Hillside Treatment Center for urgent care beds. These can also serve as assessment beds, short-term assessment beds, to help clarify the most appropriate placement for a child who is a complex presentation. In addition, for some services, there has been limited, not unavailable, but limited Medicaid reimbursable intensive in-home options. So those treatment options that we most need to leverage to prevent a child from rising to residential levels of care, or to be there to support the child and the family as they transition out of those residential levels of care. And we do have several intensive community programs with whom we have partnered for match pilots to help meet that need. Quick snapshot, who are we serving in match? Who is being referred? Well, you can see here that the itty bitties, the 0 to 5s are our smallest group of population. 6 to 9 years, somewhat more, but when children start to hit adolescence, that is when referrals start to pick up. 11 to 12, somewhat more, with our highest served or referred and served population in that 13 to 15 demographic. And you can see here we have also broken this out by the community treatment provider who treated that child. So you can see not only the cumulative ages, but which treatment program they were referred to. And then finally, the 16 to 18-year-old group. I would also like to say, and I neglected to say it on the previous slide, and I apologize, but I will say, we had mentioned earlier that those residential deepest in placements are also the most costly. So we, through Match, are looking at these community pilots through a lens not only of excellence of care, but also of fiscal responsibility. If we can treat a child at home and support the family at home and do it at a substantially lower cost, then that is beneficial through every lens. Quickly, who is referring? You can see that emergency departments are our most frequent referral supports, and also internal programming. And when I say that, I mean a program such as Devereaux, say, may have a child in a different program, and internal clinicians may say, you know, we think this kid would be better served over here. So internal clinicians, also internal clinicians within standard treatment providers may say, we're not 100% sure that this is getting what the child needs. Let's refer this child to Match. Our partners at Family and Children's Services are our next most referred referral source. Self-referral, because again, no wrong doors, so parents can bring their children to match. DJJ and or the juvenile courts, and then it gets smaller from there, from community providers, PRTF, schools, etc. With regards to insurance type, you can see that that information is not always available. But for those who are public insurance, so Medicaid is the most common insured source, and that is typically CMO Medicaid for most of Georgia's children. The majority of Georgia's children are covered through that source. Some small amount do have private insurance, and then the smallest group of all are those who are entirely uninsured. So I've talked a lot about pilots. Let's talk about outcomes. We've talked about impact. What sort of impact have we been able to see? For Hillside, they have thus far discharged 23 clients with a 78% recognition of goals achieved. For our WellRoot Community Intensive pilot, they've discharged 39 clients with a reported 56% of goals achieved. And for Youth Villages, 48 clients and 81% of goals achieved. Now, these numbers look wildly divergent, and they tell us a couple of things. One, they tell us the success of the programs, but one of the other things I really wanted to point out is that each of these is an evidence-based program. And in order to be an evidence-based program, it must have fidelity measures and benchmarks that the program must adhere to. So the fact that, say, WellRoot indicates that 56% of the kids had their goals achieved does not mean that the child's symptoms and behavior did not improve. It means that 56% of those kids met those benchmarks. So I did want to share that as well. And you can say that you can see here, sometimes children don't succeed in a community placement. As much as we will try, they do ultimately require a higher level of care. So that would be a point of transition as well. Sometimes the client and the family can no longer engage in the service and they voluntarily withdraw from it. So there are a number of reasons that a child might be considered not successful. Nonetheless, we are strongly encouraged by these results. These are small. You can notice the small numbers. That's because they are pilot programs. But these are the programs that we are learning to come to what I keep referring to as the second part of match. That is the system level of match, where we take the learnings from the data that we gather from the children that have been referred to us and the results of the pilots with whom we are engaged to say, where are the gaps in the system that the system as a whole can look at, and what are the solutions to try to fill that? So where are the reoccurring drivers, the gaps, and where are opportunities for earlier intervention? So basically, match phase 2 comes down to who, what, when, where, now. Why, right? Who are we trying to serve? We looked at some of those demographics. There were some theories about who would come to match. Now we have data, and we can give you some of those descriptive statistics. Why now? Why are they coming to match now? And this often comes back to that critical piece of conversation of, was there an earlier identification that could have been made? Was there an earlier service that could have been delivered, or an earlier support? So what has made this critical now? How did they get to match? Have they exhausted all treatment options? Were there treatment options that someone wasn't aware of? Did the treatment option not exist? So how did they get there? Where did the system fall short that they ended up with match, and that the system was not successful for that child earlier? And what could have been done differently, particularly in the prevention and early intervention space? So looking forward for that system level part of match, community programs we have identified as a potential barrier, because those higher intensity community programs are not always available, and are not always available for a full geographic area for the children, including the step down. And as we were saying, services to prevent a child from having to step up. So it works in both directions. The proposed solution is, how does the system work together to expand those services and identify the ones from which we are getting the most impact and have the highest efficacy? And match data can be leveraged to inform those conversations. Specialty residential care, limited options for kids in Georgia with specialized treatment needs. You know, again, as we are talking about the funding of the system, just about the most expensive option is to have to send a child out of Georgia. And in addition to having a dollar cost, there is the treatment and emotional cost of having to separate a child from his or her support system, his family, separate the family from the child that they wish to support and they wish to be with. So how do we address that availability in Georgia and recruit proven providers and support smaller, specialized, but data demonstrated necessary programs? We talked about, and a lot of folks have talked about, co-occurring match and, mental health and autism spectrum disorders. It is challenging for providers who support autism spectrum to treat mental health disorders, and challenging for behavioral health providers to treat autism spectrum. What are our opportunities to bring learning and services in specifically for those co-occurring kids? And transition age youth, those kids who are in the process of aging out of one system, be it the behavioral health child serving system, defects care, et cetera, into the adult counterpart. And how can those children and families best be supported through that transition? We've also identified some infrastructure challenges that we feel are worth investigating further, including, and we've talked about staffing, clinical shortages. Clinical shortages in rural areas have come up in many conversations in front of many study committees. I will not belabor the point, but looking into creative ways to expand workforce incentives and expand telehealth availability are some of the things in conversation. And finally, and this has come up as well, incomplete data that hinders our ability to get full visibility into the system. So standardizing referral processes, implementing tracking that goes across systems, developing shared data sources that allows not just DBHDD, DHS, DFACS, et cetera, but allows all of us in partnership to get greater insight into Georgia's children that we are all serving to help strengthen the outcomes that we get for our kids. So what might success for this look like for policy and oversight? Our short-term goal, or in general, our short-term goals might be greater transparency and greater data collaboration, as we are talking about. Shared priorities, which Match has been tremendously successful at. Again, we value our colleagues and appreciate everybody's seat at the table. Sharper intervention points, earlier intervention points, stronger responsiveness, and improved capacity, and those do go hand in hand. Sustainable efforts, the pilots, we're very proud of the pilots, and we feel that they are doing excellent work. They are not sustainable solutions for all of Georgia's children. So how does the state as a whole implement learnings from those to sustainable solutions for all of the state? And finally, improved outcomes. And again, bringing it back to our focus of why are costs rising, although it will take our system some time to realize the full financial benefit of early intervention and prevention services over time, as those portions of the continuum are strengthened, we will see the need for those more expensive, deeper in services decrease. But even in the short term, those interventions for younger children in the household, for the family as a whole, can recognize some real world and fairly prompt gains if intervened. Sorry, y'all. Again, this is dropping. If implemented appropriately. So here is some more information about DBHDD. I encourage you to scan our QR code. Thank you again for the opportunity to be here. Are there any questions that I can answer?
Thank you very much for your presentation. The data sharing between agencies continues to be an issue. The lack of data sharing agreements for certain things. And so we definitely still have more work to do on that. Do you have a sense of how many of the kids, you guys are the end of the line. I mean, Match is the end of the line. These are the toughest kids that we're dealing with. Do you know how many of them are going out of state? How successful you've been in keeping them in Georgia?
You have to, if Ms. Stanley does not have those, we can get those for you, but you may
I can
have.
give you I can give you a general sense. Our out of the, let's round it or make it even, out of the 500 that have been either staffed at a clinical team or put into a pilot, or we've been able to find other alternatives without a full match staffing. Out of all of those youth, maybe less than 10% have gone out of state. We've been able to interrupt a couple of those out of state placements by stepping in and addressing those needs, finding resources in state for them that would not have had that option otherwise. Our match clinical team has become very robust, and we've had a lot of additional providers join that team. So when we are staffing these really difficult individuals, they can say, "Oh, let's add this resource. Can we come into home?" And usually the parent is there, so we get immediate consent to get those services started. So there's no lag time once that staffing has completed. In some cases, that has solved some of those issues around needing to go out of state because the service wasn't available. In other cases, we've been able to delay that and support them in the community until they are until there's a bed available, just because the service wasn't in the state of Georgia and they needed that intensive option that happened to be out of state.
Thank you. Any other questions from legislators? Thank you very much for being with us. Appreciate it. And Lynette Rhodes, you are last but not least. And this is a thick presentation you handed us, so hopefully you can talk fast.
Hi, good afternoon. My name is Lynette Rhodes. I am the Chief Health Policy Officer with the Georgia Department of Community Health. Thank you again for the opportunity to present to both of our chairs and also Commissioner Burke. So I am going to walk through the presentation from the Medicaid agency. And yes, I am going to go pretty quickly, at least through the very first half of the slide deck. The information in this section, which speaks to the introduction and the background, is information that the committee members can review later at their leisure. It's really just for those who don't live in this space on a day-to-day basis, just to give you a little more insight in terms of how the program actually operates. So as a starting point, the Department of Community Health administers the Medicaid program in Georgia. We do have a combined federal and state budget of more than $20 billion. We are jointly funded by both state and federal dollars. We administer our program generally within pretty broad guidelines, and we are the payer of last resort. I'm on slide 7, just want to spend just a little moment here to talk about the federal funding. I know there's been a lot of discussions today around federal funding and where that money comes from. So I thought it'd be good just to give you a little more insight in terms of how that actually works. So we get a federal match for all of the Medicaid expenditures. That is commonly called the FMAP, or the Federal Medical Assistance Percentage. And that varies from state to state, and it varies and changes on an annual basis. So if you look on slide 8, I give you a clear purview of how much money we actually receive from the federal government. So in the state of Georgia, our FMAP percentage for federal fiscal year 26 is 66.40%, which means that is the percentage of the Medicaid expenditures that the federal government pays for. And then for federal fiscal year 27, that amount will change to 66.63%. And so the formula that's utilized to determine the FMAP for all states is that formula, and that methodology is administered by the Centers for Medicare and Medicaid Services under the Department of Health and Human Services. So we do not have, unfortunately, any stake or input in terms of how that methodology is determined. They just simply tell us what our federal FMAP percentage will be for that year. So I've given you on slide 8 our neighboring states, just so that you can compare to see what the percentages are and the differences between those states. Moving on to slide 9, we do have to operate our Medicaid program within federal guidelines and also state guidelines. We are heavily regulated and audited quite often. But each state Medicaid agency does have a little bit of discretion in terms of how they operate their programs. You will often hear, may have often heard kind of the slogan, if you've seen one Medicaid agency, you've seen one Medicaid program, because they all differ in terms of how they actually operate. But we do have what's called a state plan. So on slide 9, I talk a little bit about the state plan. It is a comprehensive document that outlines all of the services that we provide. It outlines the reimbursement methodology for many of those services. It talks about enrollment, who can be enrolled, what some of the limitations are within the program. So this is our agreement with the federal government on what services we are going to provide. And when we make changes, we have to do what's called an amendment to the state plan. And so those are done whenever we're making changes. We make those, annually, a lot of times after the end of the legislative session, once we know changes in terms of appropriations, changes in terms of policies, and to comply with state law. So I've given you the link to our state plan in case any of the members of the committee would like to go and just take a look at that document. Some good bedtime reading for you. In terms of the agencies that assist with the administration of the Medicaid program, there are several. So on slide 10, I've outlined those for you. We engage heavily with the Department of Human Services and the Department of Family and Children's Services. We do a lot of work with DBHDD. You just heard from Christy, who testified. DPH, DOE, all of the state agencies. And so in terms of how we communicate with them, it is frequent and it is often. In terms of how we engage with DFACS and DBHDD, for example, we have recurring meetings that are set with them. Those are on different meeting cadences, monthly, bi-weekly. Some of those are weekly. We meet on an ad hoc basis. We have teams of people of our staff that meet with their staff. So the engagement and the communication is frequent. And we are all working together to try to find services for our Medicaid members that we serve jointly. We operate 2 service delivery models in the Medicaid space, and a foster care child could be in either of these. There are 2. One is fee-for-service and the second is managed care. So just for those who may not clearly understand the difference between the 2, I'll take just a moment to explain that. So when we talk about managed care, What that means is the state of Georgia is contracting with an agency. That agency is responsible for managing the care of that member. In the state of Georgia today, we have 3 of those agencies. They are AmeriGroup, CareSource, and Peach State Health Plan. AmeriGroup serves the foster care population, and I'll talk a little bit about that more later in the presentation. As it relates to managed care, we pay that entity a per member per month fee to serve each member that's in their particular plan. So just as an example, this is just an example. If Lynette Rhodes was enrolled with AmeriGroup, we would look at what county Lynette lives in, what region of the state, what are Lynette's diagnoses, what are her conditions. Is she a female? Is she a male? Is she an adult? Is she a child, or is she a newborn? So all of these various factors come into play in determining how much they're going to pay each month to serve Lynette. So again, it's a per member per month fee that we pay to a particular agency. That is different from fee-for-service or traditional Medicaid. In the traditional service Medicaid program, a provider simply renders a service and then they bill the agency for that service. So those are the key details. I think the other really important component to take away in terms of differences is that in the managed care space, and again, this is the entities that we're paying to provide those services, those entities are responsible for providing care management and case management for each of the members that they serve, which is different than what you will see in the fee-for-service arena, and that's because you're basically just dealing directly with a provider versus an entity. So Georgia has had managed care since 2006. We implemented the Georgia Families 360 program in 2014. And Georgia Families 360 is specifically designed to serve the foster care population along with DJJ members and also members in adoption assistance. On slide 12, and I'm sorry, y'all, I'm moving quickly through this just so I can get to some of the major components. I've just highlighted for you some of our key managed care programmatic and operational priorities there. You'll see, for example, the delivery of care management, care coordination, chronic disease management, and of course, ensuring the provision of integrated behavioral health care. I want to talk a little bit about the services that we provide in the Medicaid space. Want to highlight a couple of things here, and these topics have come up in some of the discussion from the previous presenters. So in the Medicaid space, you have each state Medicaid agency must provide certain core basic services. So that's going to be the category to your left where it says mandatory Medicaid services. And again, I'm on slide 13, just to make sure I don't lose anyone. So these services you have to provide. These are high level categories, but they of course would include behavioral health, physical health, diabetes management, laboratory and x-ray services. So again, these are just high level descriptions here of the core services that every Medicaid agency must provide. To the right, you'll see the optional Medicaid services. And in Georgia Medicaid, we cover all of those optional and mandatory services. So members are able to receive both services. I did want to talk a little bit about non-emergency medical transportation, as that has come up a couple of times with some of the previous speakers. So in the Medicaid space, we do cover transportation. It is called non-emergency medical transportation. And then, of course, we also cover emergency transportation too. For example, ambulance, and that's ground ambulance and air ambulance by helicopter or by plane. So we cover transportation. What is different in the Medicaid space is that it has to be transportation related to the provision of some type of medical service. So that is transportation to a doctor's appointment, transportation to the pharmacy to pick up a prescription, transportation when you're discharging from a facility such as a PRTF or a hospital. So it has to be related to some type of a medical service. As it relates to the foster care population, and you did hear this earlier from one of the presenters, because they are minor children, many of them are minor children, they do have to have an escort when they are being transported. Our drivers in the NEMT program are not clinical. They're drivers. They're hired drivers that transport members. We utilize shared transportation. That's what NEMT is in the Medicaid space. So mostly those are vans. They will have more than one individual on the vans, and they make multiple stops to different appointments to drop those individuals off. And so you would want to make sure that there is some type of escort that is there, that is present with a minor child to ensure that that child gets to their destination. And also in the event that something happens on the van, they can assist with managing those particular issues. So I did just want to point that out. The second thing that I do want to mention that came up earlier has to do with psychological services. And as you can see, that is one of the optional Medicaid services that's listed, but we do cover it. And I think the specific question was whether or not the Medicaid program would cover a psychological evaluation for the parent of a foster child. The answer to that question is no, unless that parent is enrolled in the Medicaid program. So I did just want to confirm that we would cover it, but that parent has to be on the Medicaid rolls. All right, in terms of the services that we do not cover, I did think it was important for this committee to have an understanding of this as well. So I've listed for you on slide 14 those items that we don't cover. Room and board is one of those at the top of the list. So the only time the state Medicaid agency would cover room and board if it is tied to an inpatient service. So for example, a hospital or a psychiatric residential treatment facility. That's the only time we cover room and board. So placement settings such as hotels, group homes, we don't pay for room and board for those. So it's just very limited circumstances. We don't cover any type of experimental or investigational services. We do not cover services that are not medically necessary. Or any type of services that involve sitters or companions. And so we don't cover those. If we did cover them, we would not be eligible to receive the federal match. So moving to slide 15, again, these are just some high-level rules and regulations that we do have to comply with that I wanted to make sure the committee was aware of. If you look at the second bullet, there are, in fact, limitations on some of the services that we provide. We do have to make sure as an agency that we engage in utilization management. So that means we have to have prior authorizations, pre-certification. There are times when services have a limited number of visits on them. So just wanted to, again, just make sure that you all have the federal regulations and just some of the rules that we're governed by. So shifting to the Georgia Families 360 program, as I mentioned earlier, this is the program in Georgia that serves the foster care population. It is a specialized managed care program that was established specifically for foster care members, adoption assistants, and members in the custody of the Department of Juvenile Justice. Currently today, there are 42 states nationwide that serve their foster care population in a managed care setting. And as I mentioned earlier, the critical component and the reason why this was set up was to ensure that there was case management and care management for these members. This was set up in 2014, and prior to establishing this particular managed care entity, there was a significant amount of work that went into play that involved all of the state agencies coming to the table to talk about what the needs were for this population. It involved the input of several external stakeholders, some of our provider associations and our advocacy organizations. And out of those discussions and that work, we developed the Georgia Families 360 program. So if you look on slide 17 in the very last bullet, I talk about the fact that each member, each individual foster care member is assigned to a care coordination team that is specifically tailored to that member's specific needs. So each member has access to an interdisciplinary team. So it depends on what their needs are. It's person-centered. So if they have mental health needs, there will be someone that will participate on that team and on that with that member to ensure that they're getting those particular services versus physical health, as well as addressing any other social determinants of health that are needed. The care coordination team schedules appointments, they develop care plans, they identify gaps in services, they connect the members to any type of community resources and take the steps necessary to ensure that those members are getting the services that they needed. One of the focuses is on trauma-informed care. I've listed for you here on slide 18 some of the requirements of our Georgia Families 360 vendor. They do go out and provide training to our providers, our sister agencies, law enforcement officials, and judges, and they talk about the services that they provide. They get input from each of those entities to determine what is needed moving forward. So that is one of the benefits of having a specifically tailored program to assist with this population. They are also charged with developing innovative solutions, whether that be through technology, whether that be through telehealth services, to assist those members that reside in either rural or underserved areas of the state. If you look at slide 19, I've just listed for you here all of the services that would be provided through our Georgia Families 360 program. So of course, the mandatory services, the optional, and the enhanced services. So if you look at the enhanced services, I've talked a little bit already about the care coordination team that each particular member gets. They also receive complex care coordination. So for those members that have very challenging needs, that is one of the goals of this particular coordination team. We provide additional screenings, trauma assessments, and any other assessments that that member needs. We also have the benefit of providing in lieu of services in the managed care setting, as well as value-added benefits. And so when we speak of value-added benefits, those are services that you don't normally find in any Medicaid program. So these are things like free over-the-counter medications, GED vouchers, gift cards, things to incentivize that member to actually attend their doctor's appointments and to receive services. And there's a vast array of services that fall under that value-added benefits category. In terms of enrollment statistics, and I'm moving now on to slide 21, wanted you to be aware of the population and what that looks like today. So in Georgia, 72% of our Medicaid enrollees are enrolled in managed care. This includes our foster care population. And if you move to slide 22, this just gives you a little additional perspective in terms of how the various programs break out. So if you see the orange slice there on that pie graph on slide 22, that is the Georgia Families 360 population. So again, that represents approximately 2% of the full managed care population that we serve. On slide 23, I talk a little bit and give you a glimpse into the average, and I do want to emphasize average, monthly foster care enrollment by state fiscal year. So we've outlined those for you for state fiscal year 23, 24, and 25. And again, these change daily because foster care kids transition in and out of foster care daily. So that's why we just provided an average, because that number does change quite frequently. When we look at out-of-home settings, and this is from the department's perspective on slide 25, these are some of the places where we find that our foster care population will ultimately receive services. So psychiatric residential treatment facilities, I think you heard DFAC speak about that earlier. Those are our specialized hospitals. That is the most intensive level of care that a member could receive. It's 24/7. And again, the primary function is to treat those members with various psychiatric disorders under the age of 21. Of course, hospitals, group homes, and we work closely with DBHDD to place members in group homes as needed, but those are shared living spaces. And then qualified residential treatment facilities as well, and DFACS operates the one that we have in Georgia today. On slide 26, I did want to give you a little bit of insight, and this goes to the increased cost that we're experiencing. I thought you would want to see PRTF data. So we have 6 PRTFs in the state of Georgia. Combined, they have a total bed capacity of 620 beds. It is important to note that these 620 beds are shared amongst Medicaid members, commercial members, state health benefit members, and out-of-state individuals as well. So we are all sharing and utilizing the same resources. If you look in the third column, I've listed for you, and this is data from February of this year, the average number of beds that are offline due to workforce shortages. And you've heard some of our previous speakers talk about workforce concerns in the state of Georgia. And so if you look at, for example, Devereaux, so during this time period, out of the 134 beds that they had, 20 of those were offline because they did not have the staffing in their facilities for those particular beds. If you look at the very last column, I've listed for you here the average number of beds offline due to a single room. And I want to give you a little bit of context there. I've described this to other individuals as, think of this as a dorm room. And in a dorm room, you may have 2 beds, just as an example. But if we put a member in that particular room that has, I'll say, sexualized behaviors, what happens is you cannot fill that second bed. And so now that bed that's in that room is now offline to accommodate the needs of that particular member. So this impacts the number of beds that we have available. And, this happens on a daily basis. So in those instances where we don't have beds that are available in state, what happens is we then start looking out of state. And you've heard testimony about the challenges there and the negative impacts that it has on our members. On slide 27, just to give you an idea of some of the cost, for our PRTFs, in 2023, we implemented a rate increase. So I've given you the prior rates plus the rates as they stand today. So all of our PRTFs today are paid a per diem of $649.22. That's per day that they receive to treat a member. We have received communications from the PRTFs that they're seeking an increase to $800. And this is due to various factors, right? Inflation costs, staffing costs. And when you compare the rates that we're paying today to what they get from an out-of-state member, typically from someone coming from another state, they're receiving $850 to $950. So we're competing with out-of-state individuals. As a part of this rate increase that we implemented in 2023, we specifically asked each of our PRTFs to increase the number of in-state residents that would be utilizing those beds. That was something that we agreed upon. Each of those facilities signed an attestation statement indicating that they would do so, and they have in fact provided more beds to in-state residents. However, there are still some beds that are provided to out-of-state individuals. So I can definitely bring that back, Brandy. Yeah, the number of out-of-state beds. So we'll bring that back to the committee. If you go to slide 28, I talked about what happens when we have to move to out-of-state treatment facilities. And as you can see, when you look in the far right column, the cost gets even higher. This list is not all inclusive. This just highlights some of the out-of-state facilities that we are working with when we cannot find placements within the state of Georgia. And then in the middle column, just highlighting what services those particular facilities provide. When we talk about cost drivers in the foster care space, and particularly as it relates to Georgia Families 360, on slide 30, I've listed those for you here. And again, I think this is a lot of repetition of what you've heard from our previous speakers. I think we're all aligned in terms of what those cost drivers are. So increased use of applied behavioral analysis. This is under our ABA benefit. And that is because there are more kids being diagnosed with autism. And as the number of diagnoses increases, utilization around this particular service increases as well. Increased use of the emergency department. Increased use of mental health services, whether that's inpatient or outpatient. We have done an analysis to look at the top, let's say 10 to 20 diagnoses of the foster care population. And by far and large, they are behavioral health and mental health related diagnoses. Pharmacy is another huge cost driver that we're seeing with respect to the foster care population. We've done an analysis in that area as well and have a list of the top 10 drugs that the foster care population utilizes, and we can provide that to you as well. And then, as you've heard from our previous speakers, member acuity levels. So there are a lot more members that have co-occurring diagnoses, which means their level of care and their needs have increased significantly. So I think I got through that pretty quickly, I hope, but I'll take any questions that you may have.
Yeah, I thank you so much. There's so much to cover on this. And one of the things when you give us your out-of-state numbers, we need the kids that are going out of state, and we need the percent of our in-state beds that are taken up by out-of-state kids. So we need both. The thing that's confusing to me is we've got this information about denials, delays, and there's 803 administrative appeals and so on. So if the care coordination team is working together I'm sure they're part of the conversation about the level of care for those kids. So how do we end up then with 803 appeals for denial?
Yes. So our services are based upon medical necessity, and those determinations are made by clinicians. They're made by clinicians within the program. And there's not always going to be agreement in terms of what services that particular member needs. I think you find that in the commercial space, SHBP, and any health plan, you're not always going to have agreement in terms of what level of services that particular member needs. And so when there is disagreement, the remedy to that is first you have a right to a reconsideration where you can provide additional information that may impact that decision. It may overturn it, or that decision may be upheld. And if it is upheld, then that individual has the right to file an appeal and dispute that. Not all services are always going to be approved. I know you know that, but that is typically what happens in this particular space.
And the timing on the appeals process, is that because these kids they're somewhere, they may still be in the PRTF or they may be in someplace else. So is that something that turns around quickly in your experience, or is that something that drags on for weeks and months like it does with other services?
Yes, so it's two parts. If you're looking at the first part, which is the request for reconsideration, those should be done within 24 hours. You submit your additional information to that health plan, they review it, and then they give you a decision. If that decision is upheld and you then have to go before an administrative law judge, you're then going, to your point, to a separate entity. All appeals, Medicaid related, are handled by the State Office of Administrative Hearings. They handle all of our appeals for all members, and that can be a lengthy process because they are setting that down for calendar dates based upon their calendars. That is not something that we control, but yes, that can be a lengthy process.
Jim Camp.
Hey, thank you so much for being here today. This was, you went through it quickly, but a breadth of information. So thank you for that. I have a question though. Does DCH have a definition of high acuity? Because that word is used frequency and seldom defined.
Yes, so we do not have a firm definition for it. The way that we typically look at it is someone who has co-occurring diagnoses, who has a very high level of need. And so we can work on coming up with a definition, and we can share for you what that typically looks like for us. Perhaps maybe giving you some scenarios of those foster care kids who we would consider to be high acuity levels.
Thank you. It is challenging when that term is used, and it's been used by multiple people today.
Yes.
And there's not a definition because we work in the space of law, so
Yes.
we like defined. And then another question I had, you spoke at a hearing earlier this year, and the cost for the managed care per child, I believe you said at that point in time was $950 per month per child. Does that sound accurate?
I can confirm that for you. That changes from year to year, but I will get that data for you. Each year we do new rate certifications, and those change based upon utilization and other factors. So I'll send that to you this afternoon.
All right, thank you.
Yep.
Other questions from the legislators?
We know there's a procurement process going on now for new CMOs.
Yes, ma'am.
Do you have an educated guess as to when that decision might be resolved?
I do not.
Thank you.
I wish I did.
Okay, we may need more information from you later, so, but thank you so much for being with us.
Thank you.
Okay, well, we're only about an hour over time, so that's very good. I want to thank the staff and the committee members for hanging in there. And I also want to thank particularly the Casey Family Foundation for always going out of their way to help us get data that we need. Much appreciated. I also want to put in a plug for Cafe Momentum. If some of you are aware of that, they're right across the street from the 191 Peachtree building. And all of the servers, cooks, and so on are in a program run by a nonprofit. And they are justice involved youth that are trying to get back into the system. And at that place, they have gourmet food, they get their GED, they have therapy, a lot of great things. So I would encourage you all to check it out and give them your business. The food is really good. And then the next meeting is currently scheduled for September 17th. I do not think it will be in this room because I think we learned today that's a little tight in here. So stay tuned for the location. It'll very likely be in this building though, because you may have noticed there's some construction going on across the street. So again, thanks for your attention and we're adjourned.